Spana obviously mentioned about the use of these drugs and causing very thin bleb and infections. That is what we have seen in the past. But what I'm surprised is that you have gone a little later in. Most of the time we prefer in bleb-related endophthalmitis that we go early, until unless it is just a blebitis. If it is blebitis, it's fine, but otherwise, I think it's much better that we do early phospholamprotectomy, because that's how perhaps we can take care of these cases better.
Thank you. Thank you very much, Dr. Ashok Kumar. With the permission of the panelists, may I also suggest that in competitive sections, I have been witness to certain presentations in the All India Ophthalmic Society. You better stick to the title of the presentation, because you said my topic is expect the unexpected, whereas here it is bleb-associated endophthalmitis with polytrauma. I have seen judges object to any changes from the abstract that you have made, and also with regards to the data, because one of the judges did make a comment when a presenter said he had 200 cases of something, and then said, and when presenting he said 246 patients. And when he was asked as to why this is so, he said, since the abstract was presented, we have 46 more cases. He said, you are not supposed to be altering your data here. So please stick to the title that you submit, because you may lose marks if the judges unnecessarily get vexed with that change. It's just a small aside. May I now request Dr. Vijayata Riang to present her paper on herpes zoster ophthalmicus as a presenting sign of HIV disease. If you can just introduce yourself by a one-liner to start with, each one of the presenters. Sorry, I forgot to mention for the others. Yeah, it's written, okay. Written, okay.
Good morning, everyone. I'm Dr. Vijayata Riang, and from Dr. Rajendra Prasad, Government Medical College. Today I'm going to present a case on herpes zoster ophthalmicus as a presenting sign of HIV disease. For introduction, we can see that herpes zoster is a common infection caused by the human herpes virus 3. It is a member of herpes viridae, same family as the herpes simplex virus, EB virus, and the cytomegalovirus. Herpes zoster ophthalmicus occurs when a latent varicella zoster virus in the trigeminal ganglia involving the ophthalmic division of the nerve is reactivated. The ophthalmic division is involved 20 times more frequently than other division of the fifth cranial nerve. This is a case of a 58-year-old male who was driver by occupation, presenting with diminution of vision in the right side of his eye since 7 days, with swelling and pain in his right eye, with headache and fever for 3 days back. There was presence of healing maculopapular crusting with periocular edema on the right side of his face, and patient has no known history of any systemic disorder earlier. On examination, we found that in the forehead there was crusting of the maculopapule with the pigmented areas, and in the tip of the nose there was a healed vesicle. On ocular examination, his visual acuity was hand movement close to face. His eyebrows were slightly depressed. The eyelids were drooping with severe ptosis and swelling. His conjunctiva, they were congested with bulbar and palpebral congestion. This is the picture of his cornea that we see. There is a ring-shaped infiltrate which was 6 mm by 5.8 mm in the central area, sparing the 2 mm medial part of the cornea. It was hazy with irregular margins and edematous floor. It involves 70% of his trauma with eschar in the inferior medial area, which was taking the fluorescent stain. Rest the anterior chamber and posterior chamber were not visible. In treatment and follow-up, it was diagnosed as a right eye herpes zoster ophthalmicus. Oral antiviral treatment were given, and on dermatological call, a systemic steroid was started from their side. Topical antibiotics with topical fortified medications were also started, lubricant were given, and antiviral ointment was started. With passing days, there was no improvement in the ulceration of cornea and the swelling of his eye. Then the corneal scrapings with conjunctival swab were sent, which came negative. And in blood investigation, only the ESR were raised. Later, the viral markers were sent, in which it came positive for the HIV-1. The ELISA-1 ELISA was done, and it came confirmatory for HIV with CD4 count around 330 cells per mm cube. The patient was advised for antiretroviral therapy, and post starting of the therapy, there was slight improvement in the patient, and in consequent follow-up, there were more improvement. The S-char, it was reduced, and with swelling also. So in the discussion, the herpes zoster, it is an opportunistic infection associated with HIV. People with HIV are 15 to 25 times at risk of to develop HZO than people without the HIV. There could be corneal neovascularization, scarring, which can result in poor vision. There could be vision loss from optic neuritis or chorioretinitis. In case of HZO with non-healing presentation, it is important to know the immunocompromised state. And the conclusion is, this case shows the retrospective presence of immunocompromised state from the presenting illness, and in this we can say that patients and general population should be instructed regarding the importance of early presentation and careful compliance in treatment as well as the regular follow-up. Thank you.
Thank you very much, Dr. Vijay Karyan, for that excellent presentation. Almost all of them have been sticking to time, which is a good thing. May I request the panelists who do a lot of cornea work to please.
Yeah, Dr. Vijaya, this patient had detected to have HIV first, or first it was a just herpes zoster ophthalmicus?
It was just herpes zoster, sir. And later on we came to know that it was, he was in an
How idea came that this patient could have HIV?
Sir, because rest of his test came negative, and in our normal regular blood sample we used to also send the viral markers, and then they came positive.
I think in today's time, if you have herpes zoster ophthalmicus, HIV test is must. I think that is what to be remembered, because most commonly these days, herpes zoster ophthalmicus, of course it can occur otherwise, but associated with HIV related issues. Yeah.
Any immunocompromised status makes the patient more predisposed to viral infections, and that's what Professor Dogra has mentioned. Thank you very much for that nice presentation. May we move on to the next presentation by Dr. Karan Dikshit, and that happens to be a rare presentation of bilateral optic neuritis, post-viral hepatitis A infection in a young patient.
Good morning, senior doctors, colleagues, and my dear friends. Today I'll be presenting a rare presentation of bilateral optic neuritis post-viral hepatitis A infection in young patient. So, starting with the history, a 17-year-old female came to the OPD department on 21st October 2024. The presenting complaints of the female were that she had decreased vision in the left eye and pain on ocular movements over the left eye, which in duration it was since past 7 to 10 days. And she had reported mild increase in these symptoms since the past 1 day, which prompted a visit to the hospital. She was previously diagnosed as acute viral hepatitis with jaundice due to hepatitis A infection, which was confirmed by the status hepatitis A IgM positive by the Department of General Medicine 15 to 20 days ago before she presented to us. She was taking supportive treatment consisting of oral fluids, paracetamol, rabeprazole, and multivitamins. Examination. On examining the extraocular movements, there were no restriction noted with the movements, and there was associated pain in the left eye. Intraocular pressures were normal in both the eyes, 12 mm Hg in the right eye and 14 mm Hg in the left eye. Visual acuity in the right eye was 6/6 by Snellen's chart, and left eye had profound visual loss, with the patient being able to count fingers at 1.5 meters with no further improvement with the pinhole. Color sense tested with the Ishihara's isochromic plates revealed that the right had intact color sense, the left eye was grossly deficient. Pupils, there was a presence of relative afferent pupillary defect on the left eye, and the anterior segment, was unremarkable. Posterior segment revealed the presence of grade 3 disc edema in left eye and mild nasal blurring of the disc margins in the right eye, which is can be seen in the clinical photograph. The optical coherence tomography was done next, and it was significant for increased peripapillary retinal nerve fiber thickness, which was circumferential in the left eye and only involving the nasal quadrant in the right eye. Now, magnetic MRI was done for this patient. Starting from the top left and going clockwise, we have a T1 weighted section. The red circle shows a lesion which is iso-intense with the gray matter. This same lesion present in the temporal lobe was hyper-intense on T2 flare, T2 sequences with flare. The intraorbital portion of the left optic nerve showed hyper-intense signal on T2 flare sequence and post-contrast enhancement on the contrast-enhanced MRI of the orbits. Visual evoked potentials were recorded for this patient, which revealed a bilateral afferent pupillary defect, visual pathway defect, with reduced amplitude and delay of P100, the waveforms in right eye, and non-recordable waveform in the left eye. Hematological investigations were carried out, revealing microcytic normochromic anemia, which is in line with the history of infection. The other CRP was raised, ESR was raised. The liver enzymes, particularly bilirubin, was deranged, and renal function tests were within normal limits. Coming on to the other hematological investigations, the ANA was negative. The patient showed weak positivity to anti-MOG antibodies in a titer of 1:10. The other subsequent hematological investigations for anti-MOG bodies in CSF was carried out, which was again weakly positive. Oligoclonal blands in the CSF were negative. The CSF further showed pleocytosis. The patient was tested and was found negative for Sjorgen syndrome, scleroderma, systemic sclerosis, SLE, drug-induced lupus, dermatomyositis, primarily biliary cirrhosis. Management and follow-up. The patient was started on intravenous methylprednisolone 1 gram per day for 3 days under strict monitoring under inpatient care. After completion of systemic steroids, she was discharged with oral prednisolone 60 milligram per day for 11 days and supportive treatment. Upon discharge, patient reported neither worsening nor significant improvement of symptoms. She was followed up 12 days post-discharge in IOPD, showing remarkable recovery. Vision was regained up to 6:6 in right eye, and left eye was 6:6 partial. RAPD was not present. Left eye color sense and contrast sensitivity were regained. Fundus examination showed a normal right optic disc and resolving disc edema in the left eye with blurring of the nasal margins. She was put on a 3-day tapering of oral prednisolone to be decreased by 10 mg every day. These subsequent investigations were carried out on follow-up, which show that the liver enzymes had subsided and the picture of the CBC had shifted from that of anemic to a normal picture. Discussion. Optic neuritis can be associated with infectious, parainfectious processes, demyelinating conditions of the central nervous system, and may not be associated with any ongoing disease process. This parainfectious optic neuritis usually occurs 1 to 3 weeks following primary illness. Visual acuity in children tends to be worse off than adults, although the final visual outcomes were equally good and optic disc edema is usually present. Optic neuritis following systemic infection has been described with various pathogens, including hepatitis B and C. Post-vaccination optic neuritis has also been described with hepatitis A virus. Although the exact process that leads to optic neuritis following the infection is largely unknown, it can be from the either direct invasion of the organism or immunologically mediated demyelination of the optic nerve from inflammation of the optic disc vasculature. In our case, the patient had reported visual symptoms more than a week after being diagnosed with acute viral hepatitis. There was subacute monoocular vision loss, dyschromatopsia.
Dr. Kumar.
Yeah.
Sorry, sir.
I think your case was excellent, but you went double the time. So, you know, it neutralizes and make it down.
So if you have 3-4 pages on conclusion, you can just stop there because.
So, in conclusion, I would like to say that accurate and timely diagnosis of optic neuritis at presentation can be a challenge, but it is essential for the effective treatment of individuals. This case exhibits that through thorough examination and investigations can benefit both the clinician and the patient vis-a-vis treatment options, prognosis, and future risk stratification. Para-infectious optic neuritis is a careful diagnosis of exclusion. We exclude other prevalent causes of optic neuritis first. Prudent interpretation of radiological as well as serological findings is a requisite in navigating the convoluted pathways of diagnosis.
Thank you, sir. Would anyone of the panelists have any discussion for this, or shall we move on to the next one?
You mentioned about anti-MOG
Yes.
antibodies. So is it possible that it may also be related to that area, or we have to keep that thing in mind for future? Because if we just put everything on, you see, viral hepatitis, so because why, or is it known that you could have anti-MOG antibodies in viral hepatitis?
So post-viral infection, there is incidence of demyelinating events owing to the primary pathology. The cross-reaction between the viral antigens can trigger demyelination. So that may lead to a positivity of anti-MOG in the patient. Whereas if we talk about anti-MOG specifically, it has been shown that it has a positive predictive value of 72% to 90%, which increases with the dilution of the titer. In this patient, she was weakly positive to a titer of 1:10. Subsequently, we reconfirmed the diagnosis that she had this positivity in the CSF also, sir.
Thank you, Dr. Karan. With that, we move on to the next presentation by Dr. Mayur Garkar, a case of bilateral corneal ulceration leading to diagnosis of a systemic autoimmune disease.
Good morning, everyone, all the respected members and all the respected doctors present over here. I am going to present a case of a bilateral corneal ulcer leading to a diagnosis of a systemic autoimmune disorder. With a history, a 38-year-old male driver by profession present to the IOPT at Dr. RPGMC Tanda with a chief complaint of redness, pain, foreign body sensation, photophobia, and diminution of vision in right eye since 4 months and left eye since 3 months. The symptoms were insidious in onset and gradually progressing. If we talk about the past history, the patient visited to the private hospital where he was diagnosed with a keratoconjunctivitis sicca bilateral eye with a sealed perforation left eye due to Sjogren syndrome. The patient is non-smoker, occasionally drinks alcohol, no history of a similar complaint in the past or in the family. If we talk about the ocular examination, the visual acuity of a patient was 3/16 to the right eye and 5/16 to the left eye, normally reacting pupil and unrestricted extraocular movements. Eyelids were in the blepharospasm. We have performed the Surmer test for which for the right eye it came out to be the 1 mm and the left eye it came out to be the 0 mm. The conjunctiva was dry looking, congested, and cicatrizations were present. The sclera was within normal limit. If we talk about the cornea in the right eye, the corneal thinning was present with a desmetocele and an FS positive defect of a 3.9 into 2.8 mm. In the left eye, there is a sealed perforation. The anterior chamber of the right eye shows a grade 1 hypopyon and the left eye shows a grade 2 reaction. Iris was within normal limit, but in right eye and in left eye, there is an adherent glaucoma present. If the lens and the fundus of the right eye are not visible due to the media haze, in the left eye they are within normal limit. The IOP was digitally normal. Here is a diagram which showing the desmetocele and a corneal haze into the right eye with a FS positive defect. And in the left eye, here is a sealed perforation and some bands of a cicatrization were present over inferiorly in the palpebral conjunctiva. If we talk about the general examination was almost normal except the history of a recurrent oral ulcers were present in the patient. Here are some photographs of oral ulcers present over here. All the hematological investigations were normal except the ESR which came out to be the raised to 30 mm per hour and the ANA profile which came out to be the negative. Corneal scraping was sent to rule out the infective etiology or a superadded infection which came out to be the negative. After the ocular, general and the routine hematological examination, the following differential diagnoses were kept. First is Sjogren syndrome, mucous membrane pemphigoid and Behçet's disease. Till that the treatment was given of a topical antibiotic, eye lubricants, cycloplegics, IOP lowering drugs and BCIL with a glue paste into the right eye. The dermatological opinion was taken for the oral ulcer and cicatrization of a conjunctiva, and the oral biopsy was performed from the lesion which came with the result of a stratified squamous epithelium with a suprabasal split and a bullous formation with tombstone-like appearance, which was suggestive of a pemphigus vulgaris. If we can see here is a tombstone appearance present and a ruptured bulla over here and a split in the dermis and epidermis. After the biopsy report, we came up to the diagnosis of active keratitis right eye with a sealed perforation left eye, secondary to the oculocicatricial pemphigoid. What's the conclusion? The pemphigus vulgaris is an autoimmune disorder affecting the skin and the mucous membrane. The ocular involvement in the pemphigus vulgaris has been reported, but its prevalence and the clinical characteristics are not well differentiated. It is a type 2 hypersensitivity reaction which is the formation of an antibody against the protein of an epithelial basement membrane of a conjunctiva that causes the goblet cell destruction and lead to the unstable tear film formation. Involvement of a cornea is rare. The corneal involvement can increase the risk of a blindness if delayed in the diagnosis and the management. Early detection of ocular manifestations in this disease is vital. Management usually include anti-inflammatory and immunosuppressive medications. Thank you so much.
Thank you very much, Dr. Mayur. Comments from the elite panel, please.
I think the whole thing was on the Sjogren syndrome initially.
Yes, sir.
So nobody suspected ocular pemphigoid.
Yes, sir.
Because why I'm bringing it out, because we, although it's not my specialty, but sometimes we do come across patients, because this could be a very serious situation.
Yes, sir.
So you have to put them on immunosuppression, and long-term treatment is required, otherwise they totally scaterize, as well as the perforation you have seen. It could be a very serious situation. So I think the proper diagnosis, which is not there, and we have seen some, I have seen one very elderly patient who was very disturbed because he lost vision because of, he was not diagnosed, and he went across all over. So it's very important to do that, absolutely.
It can be unilateral to begin with, and that's where you make a mistake. You think is one eye is only involved, and unless you investigate systemically, you may not find anything. So there, I think the role of biopsy is very important.
Yes,
Plus,
sir.
more important than you have to suspect that the clinical findings. If you're getting subconjunctival fibrosis or something like that, I think you have to be alert on that. Because I happened to see a patient who was treated one eye for a dry eye and something, and later on he developed symptoms in the other eye also. That's when we got suspicious that this is not just a dry or something. There's something more than that. So this is very important, I think, to recognize. I have a feeling that this condition is under-recognized in the clinical practice, and many of these patients are treated like dry eyes for several years before the actual diagnosis is made.
Many of us, please.
Your case was very, it was excellent case, but you should have the precision of conclusion.
Yes, sir.
You should not have in 10 line, 12 line, you can say in 2 line.
Yes, sir.
And if you go beyond time, so that 10 line you can say in 1 line and curtail it.
Sorry, sir, for that.
Yeah, these are just suggestions for your next presentations. Nothing critical about your own presentation now. Which is why thank you very much, sir. Some of our teachers used to emphasize that you have to be a physician first and then an ophthalmologist next. And even there, a super specialist is someone who knows more and more about less and less, becomes a bit of a problem. So you have to have a broad-based understanding. I call Dr. Ridhima. Is Dr. Ridhima here? Dr. Ridhima was supposed to present the next one, but she's not here, I think. Dr. Hiteshi Bharadwaj. Yeah, please come up onto the dais, please. She will be presenting correction of localized cicatricial ectropion of the upper eyelid with punctal eversion.
Good morning, everyone. Myself, Dr. Hiteshi from IGMC Shimla. My topic is correction of localized cicatricial ectropion of upper eyelid with punctal eversion, a surgical challenge. We presented to the 19-year male patient with the outward distortion of the middle aspect of the right upper lid from 10 years. He was unable to close his eyes completely. It was associated with redness, watering, and foreign body sensation on the middle aspect of the right eye. He presented with a history of fall 10 years back on the level ground, which led to the trauma over the right upper lid and impaction of the foreign body inside the orbit, for which he went to the nearby hospital and the part of foreign body was removed over there. He was referred to the our institution, where his right orbit was explored and 2 big foreign bodies were removed from the middle side of the right orbit. He developed a discharging fistula medial to the medial canthus and was explored again after 2 weeks, and 1 more foreign body was removed. Thereafter 3 months, he developed outward turning of the upper lid medially. He was operated for the same in 2022, and an epidermal skin grafting was done. The graft was taken from the right arm. Partly the patient improved, but the residual upper lid distortion remained. Unfortunately, the graft fell off and the patient again reported with the cicatricial ectropion. Systemic examination and the general physical examination of the patient was normal. In the local examination, there was a cicatricial ectropion involving 3 to 4 mm of the upper eyelid medially with punctal eversion. It was associated with exposure keratopathy medially. The visual acuity of that eye was 6/6, and the ocular movements, rest of interior segment and fundus were within normal limits. In the ocular examination, the visual acuity of that eye was 6/6. Pupillary reaction was within normal limits. IOP was 12 mm of Hg. Ocular movements were full and free. Forehead was normal. In eyelids, there was a cicatricial ectropion involving 3 to 4 mm of the upper lid medially with punctal eversion. The palpebral facial horizontal was 28 mm and vertical height was 7 mm. The sclera was normal. Conjunctiva was congested. In the cornea, there was exposure keratopathy, and the iris, interior chamber, pupil and lens were normal. Now the surgical technique. An H-shape incision was made in the upper eyelid starting from above the upper punctum and laterally ending above the eyebrow. The incision was deepened to release the fibrous and contracted tissue. The measurement of the raw area was taken to harvest the full thickness skin graft of 10 to 15 mm from the left inner arm. After being placed over the recipient side, the graft was sutured to the edge of the defect. The sutures were later used to tie over the bolster in order to prevent the movement between the graft and the bed. The compression bandage was done. After 5 days, the patch was removed and the graft was well exposed to the underlying tissue. The contour of the upper lid was restored medially along with the restoration of the normal punctal anatomy. There was no pus discharge. The sutures were intact and were removed 7 days post-operatively. However, just to prevent the cicatricial contraction in the post-op period, 2 traction sutures were taken on the medial side at 2 weeks to the lateral aspect of the lid, which are removed after 2 weeks. Discussion. The upper eyelid covers 90% of the eyeball, and hence the slightest defect in the upper lid will result in exposure keratopathy and tear film instability. Ectropion is a version of the eyelid margin where the lid is pulled away from the globe. Now the causes of cicatricial ectropion were trauma, burns, post-blepharoplastic complications. The rare causes include osteonecrosis, necrotizing fasciitis, fungal infections, osteomyelitis. In the present case, there was traumatic cicatricial ectropion in the upper eyelid medially. Repairing ectropion poses a significant challenge for the surgeons. A detailed preoperative evaluation of the ectropion cause and primary location is essential for the effective treatment. The reconstructive procedures depend upon the size and position of the defect. Harvesting the skin-free flap can also be very challenging because of thin papery skin, and these kind of grafts are notorious for poor uptake and survival. In the present case, a full thickness skin graft from the inner aspect of the left arm based on the size required was taken. In the present case, a free skin graft in conjunction with release of the underlying fibratic contracture was done to reduce the tension around the site, thereby enabling both anatomical and functional restoration. The challenges encountered in this case were proximity of upper caniculi and inversion of the upper punctum, and to create a groove or furrow so as to establish a firm adhesion between the graft and the host bed.
Can you please conclude?
Eyelid injuries often lead to disfigurement, functional loss, and in extreme cases visual loss. A strategic surgical procedure and meticulous grafting is essential for enhancing cosmetic appearance and restoring functional integrity, improving the patient's quality of life. Thank you.
Thank you very much.
I think you use a lot of description in the beginning, for the antecedents of the case, but your actual, what you did was very little. I think your actual presentation was just about 2.5 minutes or 2 minutes. Whatever you said before that was not required, right? So this is for your, future presentation, that you focus on what you want to show. That's number one. Second is that you did a free graft for this patient, right? Did you consider some rotational graft or, some other procedure there? Because if you have, if you, do some kind of rotational graft surgery, the success rate will be much higher. And if you're doing a free graft, there are more chances of failure and more chances of scarring would be there. So were there any other options available in your case which you thought could be done?
So any other rotational flaps can also be taken from the forehead, from the facial skin, or from the temporal skin. And the post-auricular site is avoided because of increased risk of contracture in that case.
Thank you very much for that nice presentation. Maybe go on to the last presentation by Dr. Rajan Sharma, who is actually a co-host for today's program. He will be talking on limbal stem cells culture and exosome-based research and therapeutic applications.
Good morning, everyone. Good morning, esteemed judges and my seniors and my colleagues. So my topic for today is isolation of limbal stem cells, stromal cells, and exosomes, which was a collaborative effort. So the aim of the study was to culture limbal epithelial cells, stromal cells, and to extract exosomes from the limbal biopsy post-keratoplasty, which is the corneoscleral rim left after we take the cornea and use it for the PKP procedure. So we took the limbal biopsies from the corneoscleral rim, and we sent back the biopsies in the same media to the lab by air, which is in Bangalore. So we dissected the limbal biopsies as seen in the first photograph and transportation of the biopsies. The steps followed were according to the protocol in the literature. The cells were cultured in a 6-well plate at a density of 5 into 10 raised to power 5 cells per millimeter square, and incubated in a carbon dioxide incubator, and aspirated the spent media, used trypsin and centrifuged the tubes, and the pellet cells at higher speed compared to live cells for 5 minutes. The objective of the results showed the limbal stem cells expressed the markers ABCG2, CD44, P63, and Vimentin markers, and these are the overlay graphs which represent the fluorescence intensities of the conjugated isotype controls and limbal stem cell marker antibodies. So the corneal stromal stem cells, these are the native human corneal stromal cells obtained by standard outgrowth technique, typical fibroblastoid appearance and elongated and spindle shaped. These are normally quiescent cells situated between the lamellae, and if activated, they undergo fibroblastic transformation and myofibroblastic differentiation. The markers expressed were CD73, 90, CD alpha SMA, and CD73 and PAC6, and it was negative for CD33, 133, and 45. So we also derived exosomes from the limbal biopsies, the culture media of the cultured cells. These are the bilipid membrane-bound nanovesicles, size between 40 to 100 nanometers, and they are cargo which transfer bioactive molecules secreted by cells for cell-to-cell signaling. They play important role in wound healing and angiogenesis. So in our results, we derived exosomes, and as seen in these photographs, the physical properties were sized. They were sized between 50 and 100 nanometers, and zeta potential was between -1 and -4, which is important and it indicates high colloidal stability if it is less than -20. The applications of this study can be basically into research or clinical application. Research can be cytotoxicity studies on the cell lines and wound healing studies, and surgically it can be applied to as a cultured limbal stem cell transplant for limbal stem cell deficiency. In our in vitro scratch assay for wound healing, we observed increased wound healing of the exosomes on the stromal cell wound as compared to the untreated control. We also did cell internalization study, and the presence of exosomes stained with PKH26, which shows red fluorescence in human corneal stromal cells. And we can see the merged exosomes in the cells in the third photograph. So we have done cytotoxicity study of a novel combination autologous serum with cyclosporin, recently published in Current Eye Research. And this was done on the same cell line, and it showed good activity as compared to serum alone or cyclosporin alone. And this is a novel combination studied for the first time. Normally the serum is used in CMC or sodium hyaluronate. Surgical application is cultured limbal stem cell transplant. In this, the operating surgeon was senior surgeon Dr. Ashok Sharma, and it was done in collaboration with Reliance Reli Netra Lab from Mumbai. We took the biopsies and sent back the biopsies to the lab. As seen in the first photograph, the biopsies being taken from the patient, and it was sent back to the lab, and the cells were cultured. And we transplanted the same sheet of cells on amniotic membrane back to the cornea of the patient. We can see good results, and the cornea has considerably cleared in the unilateral limbal stem cell deficiency cases. These are the few other studies from our part of the world on clinical application of the cultured limbal stem cells. Conclusion of the studies, it was a collaborative low-cost model for cornea surgeons and researchers in developing countries like India. And we successfully cultured the cells, and the time from cornea procurement to keratoplasty to the limbus biopsy excision to the transport and to the lab took around 4 to 5 days. And we successfully cultured the cells and also derived exosomes. And it explores the possibility of building a collaborative model as I said, for research and clinical application. Thank you.
Thank you, Dr. Rajan Sharma. I couldn't dare cut him short because he's the host, so he won't invite me next time. So that's the thing. But he's a very avid researcher, and he has a fetish for publishing, so he has an academic bent of mind. Thanks for that excellent presentation. Would there be any comments on this paper, please?
Dr. Rajan, it was excellent study.
Thank you, sir.
And it has a lot of clinical implication.
Yes, thank you, sir.
But I think you should stay within the time limit.
Right.
That is for all the presenter, particularly in the competitive section.
Right. Thank you, sir.
Otherwise, it was just excellent.
Thank you, sir.
Yeah, but what Professor Jagatram said is extremely important for the postgraduates. Timing is of the essence. If your paper is brilliant and you have overshot the time, it's just like negative marking in an examination. You answer all the questions that you know, but leave out what you don't know. In your attempt to answer all the questions, you get a lot of questions wrong. You may get the net score will be very low. So that's the take-home point. So with that, we have successfully come to the end of the first session. As I said earlier, the marks will be collated by all the judges, and we'll give you the results. The organizers will give you the results at the end. May I take the opportunity to really thank all the judges for coming on a wintry morning right on time and judging this particular event. We now move on to the next session. Several of the judges in the first session will also remain back as chairpersons. I invite Professor Arun Jain, who is already here, Professor Ramlal, Dr. Rakesh Bansal, Dr. Parul Ijpujani, Dr. Rohit Grover, Dr. JP Singh, to please come up to the front to be chairpersons for this session. Rajan, mark sheets to be correct.
We have to have a volunteer for that. नहीं है क्या सर? Same here.
May I request everyone in the audience to please be seated, sir. Professor Jagatram, who was my teacher and professor during junior residency, subsequently went on to become the dean and the director of PGI Chandigarh, and also got the second highest civilian award of our country, Padam Shiri. I have great pleasure in welcoming you, sir, to give your talk on cataract surgery in uveitis, a video presentation. For those of us who are lucky to be his students, I can say this much: some are born surgeons, some become surgeons, and some have surgery thrust upon them. Professor Jagatram is in the first category, and only about 15% of our ophthalmic fraternity will be born surgeons. The remaining, the majority of us become surgeons by our effort. His surgery was simply music. I request you to please present, sir.
Thank you, Dr. Kumar, for just so kind words and heart-touching words. And I'm thankful to, first of all, I'm thankful to Dr. Ashok Sharma for giving me this opportunity to show my video on cataract surgery in uveitis patient. So I will go directly to the video. This is one patient with uveitis cataract having 360 degree of posterior synecdoche, and here we planned because it was a recurrent uveitis, and here we gave Ajudex injection 3.5 mm from the limbus, and this is followed by synecdoche and application of iris hooks, and then staining of the visibility was poor, but it was a soft cataract. Emulsification was done, and removal of the nucleus and removal of the cortex from the capsular bag was done, and in the bag implantation of IOL. Then removal of iris hooks and removal of viscoelastic from the anterior chamber. And this is another patient. Here also 32-year-old female patient, healed uveitis, posterior synecdoche. Here also we gave Ajudex injection first. I am not showing here in this case. And then here also 360-degree posterior synecdoche. Synecdoche was done, and then Malyusian ring was placed. In the first case it was iris hooks, here it is a Malyusian ring, and it gives excellent dilatation of pupil. It was a soft cataract, but what should be perfect? Your rexis and surgical step should be excellent, and this is followed by phacoemulsification. Then implantation of IOL in the capsular bag. Always it should be in the capsular bag. Except if you have a PCR. So this is how you remove this Malyusian ring, and then you remove viscoelastic from the anterior chamber. And this is another much more difficult child. This is a 1-year-old child with bilateral infantile idiopathic uveitis. You can see the posterior synecdoche. This was sent from the uveitis clinic for surgical procedure, and this child was advised they should be injected with the Azudex. So here Azudex was injected into vitreous cavity. Synechotomy was done, and this has given excellent dilatation of the pupil. It was adequate dilatation here after synechotomy. Then this was followed by continuous curvilinear capsulorhexis and hydrodissection, and removal of the cortex from the capsular bag. You can see the Azudex here, but since it is a 1-year-old child, we plan to do primary posterior capsulotomy. This is limited anterior vitrectomy, and then implantation of hydrophobic acrylic IOL into capsular bag. And we always put suture, particularly in the main incision, sometime even on the side port incision. So this is, we have already placed suture. Thank you very much.
Thank you very much, sir. Although this is not a competitive section, we have given you full marks, sir, for those excellent array of cases that you presented. Cataract surgery in uveitis is a totally different ball game, and it's not another routine case of cataract. You will be faced with multiple intraoperative as well as postoperative problems. Would any of the chairpersons have any comments to make or suggestions to offer?
I think everybody is kind of
flabbergasted with
yes,
doctor.
absolutely.
Now, just one question: do you start oral steroids also in, especially in adults, because cases which are
many of the patient where because we have to at least as per uveitis clinic our norms and international norms, I has to be silent at least quiet for at least 3 months.
And Ozurdex is...
And many of these patients, they are on systemic steroid. Except this child was not on systemic steroid, but other patient, even if I was quiet, they were put on systemic steroid and it was tapered. And in the post-operative period also, they had frequent topical steroid and cycloplegic.
And when the eye is quiet, when you operate, is it important to give Ozurdex also along with this if the eye is quiet?
No, actually these are the patient where there is a recurrent uveitis, or there is a macular involvement where there is a cystoid macular edema, or these are the recurrent uveitis patient, or wherever there is indication for Azudex. Not all patients will give Azudex. Thank you so much.
Thank you very much, sir. We move on to the next presentation by Professor Suresh Gupta, who heads the Department of Ophthalmology at GMCH, and he has special interest in glaucoma. He is an alumnus of PGI Chandigarh. Professor Suresh Gupta, please. He'll be talking on GDD in post-keratoplasty glaucoma. I think as the presentation is getting ready, in reply to Dr. R.K. Bansal's question, I am reminded of a famous quote with relation to bed sores. They say you can put anything on a bed sore except the patient. So similarly, you can put anything in an inflamed eye except more inflammation. So if the eye has a propensity to develop more inflammation post-op, depending upon the etiology of the uveitis, then we may be justified in giving intraoperative Ozurdex also. But we have to deal with that on a case-to-case basis.
Very good morning. At the outset, I am grateful to Professor Ashok Sharma for the invitation and for organizing such a wonderful meet. And I'll be speaking on glaucoma drainage devices in refractive post-keratoplasty glaucoma. Post-penetrating keratoplasty glaucoma, in fact, is quite common, and any rise in intraocular pressure after PK is considered glaucoma. And just like other secondary glaucomas, we don't have to wait for optic nerve head changes or visual field to show any changes before we start the treatment in these patients. And incidence 9 to 31% cases have been reported in early postoperative period, and it rises to 35% in late postoperative period. And it's very important, in fact, second leading cause of graft failure after penetrating keratoplasty. And these are all risk factors for post-penetrating keratoplasty glaucoma. You can see previous failed graft, or when you're combining keratoplasty with cataract surgery, any presence of pre-existing glaucoma, perforated corneal ulcer with then formation of adherent glaucoma, ICE syndrome, or patients having trauma. So all these basically predispose patient to higher incidence of post-keratoplasty glaucoma. And mechanism of glaucoma after keratoplasty is combination of open angle as well as angle closure mechanisms. So no, and it's quite complex mechanism involved in post-penetrating keratoplasty glaucoma, and one patient can have mixture of all these mechanisms, making it more difficult to manage, and it also poses diagnostic challenges to the treating ophthalmologist. Measurement of intraocular pressure is a big challenge, and then optic nerve assessment, visual field analysis, and angle assessment is also sometimes not possible because of the failed graft or opaque cornea. And in IOP assessment, you have irregular Myers because of the surface defective topography. And you can use alternative to Goldman applanation tonometer to assess intraocular pressure, and tonopen is a good alternative because the tip is small and you can use any normal area of cornea for assessing the intraocular pressure. Angle assessment, gonioscopy is not possible in most of the times, and then you have UBM and A-segment OCT. UBM can assess the angle as well as you can establish the exact mechanism of glaucoma, and it can be beneficial when you are planning surgical management of these eyes. You can select the area where you can put the tube of the implant. And in T-segment OCT, again it can assess the angle, and it has additional advantage of being non-contact. Optic disc evaluation, again because of opaque cornea, it's difficult to assess. We can't visualize even with indirect ophthalmoscopy. Then B-scan ultrasonography can help us in assessing the optic nerve head. And assessment is important because when you are planning a surgical intervention, we have to be very sure that patient has good visual potential. Only then we should be intervening surgically. And with ultrasound, you can pick up cups which are more than 0.7. So at least you have some idea that patient has some visual potential, and then you are justified in going for surgical intervention in these patients. And preoperative evaluation, the detailed examination as we do in all patients, and counseling is quite important. You have to inform patient about graft rejection and graft failure and other complications of implants, because implants are the mainstay of treatment in these eyes, and also patient will require eventually postoperative medications. Management, again, medical management is till the patient is ready for surgery, and laser iridotomy or laser iridoplasty, sometimes if patient has more of angle closure mechanism and cornea is clear, then probably you can do laser iridotomy. Otherwise, it's surgical management, trabeculectomy with mitomycin C or glaucoma implants. TRAB basically with mitomycin C shows good results, but recently implants have become more prevalent and more surgeons are opting for implants in these eyes. If you look at the success rate, the cumulative probability success of implants is little higher than trabeculectomy with MMC, but the endothelium is a big area of concern. The damage to endothelium by the implants and incidence of graft failure has been reported to 10 to 51%. And if you repeat specular, it will show progressive loss of endothelium over years, and incidence of graft rejection is also higher in these eyes, reported to be 31%. And the alternative, since it's mechanical trauma because of endophthalmodonesis, the tube, if it's in the AC, it's constantly touching the endothelium and damaging it. So if you keep the tube away from the endothelium, if you put the tube in the sulcus, then probably you are able to avoid future damage and further damage to the endothelium. And this is our departmental study published in IGO. It included 66 eyes, and in 43 eyes the implant has been put in the ciliary sulcus. Because lot of patients having post-penetrating keratoplastic glaucoma are pseudophakic. So in pseudophakic eyes, you can put the implant in the sulcus. So 23 eyes have implant in the anterior chamber, and we found that the graft was better, or there was less risk to graft if you put the tube in the sulcus. So it's small video showing the technique of putting the implant in the sulcus. After putting corneal traction suture, with BSS, you raise the conjunctiva, it will mechanically separate conjunctiva from the underlying sclera, and then you make a fornix-based conjunctival flap. Then you remove any episcleral tissue. The priming of implant is very important. It has to be gentle in valvular implant like AGV, because otherwise you can damage the valve. So after priming, you put the implant and you suture it to the underlying sclera. And when you are putting the implant in this sulcus, you have to go to 2.5 millimeter from the limbus. You create a track with 23G needle, and you go behind the iris. This is implant is being fixed with 9-0 or 10-0 nylon suture. And tube is being anchored to the underlying sclera again with 10-0 nylon. And now it's 2.5 millimeter from the limbus. With 23G needle, you create a track. Since iris was deficient in this patient, we could see the needle very easily. Otherwise, in the pupillary area, you can see the needle and you are sure that you are in the sulcus. And then tube is being inserted in the sulcus. Then routinely you cover the tube with scleral patch graft, partial thickness scleral graft, and then you suture the conjunctiva with 8-0 Vicryl suture. So few of our patients in the postoperative period can see the tube in the sulcus. You can see in the pupillary area. So take home message from my presentation is PPKG is a fairly common problem, and it poses a diagnostic as well as management challenge to the ophthalmologist. And implants, they are good option in managing glaucoma in these eyes. And however, endothelial decompensation is a major issue. And if you are able to put implant in the sulcus, and if your patient is pseudophakic, then probably you can save the endothelium in the long run. And specular microscopy should be done in these eyes to look at the endothelium. and aggressive management is key for managing these eyes. Thank you very much.
Thank you very much, sir, for that excellent presentation highlighting unique problems post-keratoplasty, particularly as relevant to glaucoma. Any of the panelists wanting to discuss, or shall we move on to the next presentation, which happens to be by Dr. Rakesh Kumar Bansal. Dr. Rakesh Kumar Bansal was my first senior resident when I joined the Department of Ophthalmology. Sir, I offer my salutations to you.
Thank you.
And he was also the head of the department at GMCH, and
That's wrong.
He was
I was
working-
never.
He was in GMCH and he had a brief stint in Muscat, and now he is currently in private practice along with his son. He'll be presenting his presentation on -6 diopter IOL implantation, a challenging task. That's an interesting paper. We look forward to that.
Yeah. Thank you, Dr. Kumar. It reminds me of those days when you were resident with us at PGI Chandigarh. So nice to see you back after a gap of about 5-6 years. I think you came when Professor Amod Gupta retired, so he was there for that party. Yeah, so nice to see you back. So at the outset, I'd like to thank Dr. Ashok Sharma for giving this opportunity. Mine is just a single case, and it's a challenging case in a way that sometimes we do face a problem, especially when we are implanting a lens, and that too of a minus power. So this is a 29-year-old male who came in the month of March to us. He was having poor vision right from the childhood, and you can see the visual acuity was just counting finger and counting finger 2 meters without glasses, which improved maximum to counting finger 3 meters and 4 meters respectively, and just look at the power. So he was using -19.5 diopters in the right eye and almost same spherical equivalent in the left eye. And somehow this patient has already gone peripheral laser because somebody had seen him. He was having kind of a degenerative myopia and thought that why not to do a Braz laser. So already it was done there. And patient wanted to get rid of glasses. So the only option for this patient which was available, if you look at the biometry data, the cornea is quite thin, and laser was not possible because of the two reasons. One, cornea was thin and power was very high, which is not possible to correct by refractory errors. And then if you look at the calculation, the IOL power, Barrett formula is showing -6.5 for both the eyes. So since patient was a myopic, so thought of putting a -6 diopter lens just to keep him little bit myopic. The posterior segment, you can see the changes, peripapillary crescent and a tessellated fundus with macular little bit thinning in this patient. So we gave a guarded visual prognosis for this patient. So this video will show the problem that I faced during implantation of that meniscus lens with a very thick edges because lens was -6 diopters. So this video will be going for AIOS also. So clear lens, you can see no cataract at all. Very high myopic patient under topical anesthesia. Surgery was planned. Capsule was stained to, because this was a young patient. So I planned to stain the capsule to have a better capsular access in this patient. So about 5.5 to 6 millimeter capsular access was done. So here the capsule has little bit tendency to go towards the periphery. So use your Trata forceps to complete the axis here. So he had no cataract at all, so was not very difficult to remove the lens matter. So just use coaxial, the bimanual IA irrigation to remove the cortical matter and whatever the part of the nucleus and the epinucleus was there. So phaco power was not required at all. So now watch this loading of the lens, how I face problem. This is a -6 diopter lens, keep in mind. So the lens is not just getting into the slots of the cartridge. So I'm trying again, that lens should get in there. It was not getting there. Then try other way around to push the lens into the cartridge, but see the edge is not getting there. So again try to push it from the back so that lens gets nicely into the cartridge, but still not getting there. So not able to push the lens forward. So this is a sensor lens because minus power is available only in the sensor. Now again I tried to push the lens there, lens got in there, but just see, before implanting the lens, I wanted to see whether lens is coming forward. Now you can see the leading haptic is not there. So the leading haptic is broken, it is left behind. So see, the leading haptic is not there at all in the front, only the trailing haptic is there. So this is the trailing haptic which we can see. So what to do? Luckily I had another lens because this patient wanted surgery in both the eyes. So -6 diopter for the other eye was available. So I had to enlarge the incision to 5.5 to 6 millimeters so that I could implant this lens in the back. So the wound had to be sutured. After 2 days, I had planned surgery for the other eye, and this time I did not try at all to push the lens into the cartridge because that was the only single lens available that time. So I enlarged the incision and implanted the lens. So both eyes, this is the other eye, which was done after about 2 days time, and got another lens of -6 diopter for this patient. So just wanted to show that difficulty sometimes we face in implanting kind of lenses which are rare. Now you can see these are meniscus lenses. So sometimes we do face problem. The model is AR40M, and because the edges you can see for the minus lens are very thick here, and as the power goes more towards the negative, the edges become more and more thick. So I asked the company whether do they have some problem with the cartridge or something, but they never came back and told that this is a kind of problem which one can face. Somehow the patient did very well during the post-operative period, and he had completed about 4 months of follow-up. The uncorrected visual acuity, which was just counting fingers, he improved to 624 in both the eyes, and with the little correction of myopia, he improved to 612 and 69. So he is very happy now. And refractive lens exchange is an option sometime if we are not able to go for the SMILE or any refractive procedure. The best corrected visual acuity does show some improvement, especially when we implant a lens or ask the patient to use contact lenses. The meniscus lenses can pose loading issues, especially if power is more than -5. And retinal examination in such patients before surgery is very, very important because these are very high-risk patients who can develop retinal detachment later on. So that's all. I wanted to show one case of a challenging situation which one faced. I want to know from Professor Jagatram, does it happen that minus lenses, you might have implanted so many minus lenses?
Yeah, you are right, your video was excellent, and this is a real problem, that edge of the lenses are thicker.
Yeah, especially minus lens, because
minus
we are
lenses.
in the habit of putting plus lenses which has a thin edges,
Yeah.
and it is thick in the center. So it's thin in the center and thick in the periphery.
Sometime hypermetropic, suppose it is 34, 35 diopter, for that cartridge has to be different, no? That is one. And for this type of lenses, edges are thicker. So this problem can happen. So one has to be very, very careful.
But does company make different cartridges? I don't
no,
think
they make cartridge, I think, A, B, C, and...
no, for the sensor lens, do they have different cartridges for plus or minus, high plus or high minus lenses?
Sir,
they have
holder and folder, the instrument we use to work for 3-piece lenses. Holder, first holder, and then is fold with the special forceps for that. You have not tried that way.
No, I don't have that now, because we used to use many years back, but those folder is not available now.
Maybe we have to bring it to the notice of these lens manufacturers also that we have a problem with these cartridges and we need a different one. We might be well within our rights and requirements to request them to change. Two other practical points. Thank you so much, sir, for that excellent presentation. The moral which sir also referred to, whenever we have a patient with an unusual out of range lens requirement, even if you are not operating on the other eye in the near future, always have 2 or more lenses, as a standby in case something wrong happens with the lens that you are trying to implant. Otherwise, you will be in soup. The second problem which I have noticed, when you are implanting one-piece lenses in the range of say -1 or -2, as you are checking the plunger to note the resistance, if you are applying the same pressure to get a little visco out, the lens gets ejected out because the friction is very less because it's very thin in the center. So be very careful when checking for the resistance and pushing the plunger. Be very gentle, otherwise the whole lens gets ejected out. So those are some points which I thought I will bring to your notice. We will move on to Dr. Parul Itpujani, who will be talking on when to consider IOP phasing. Dr. Parul is professor at GMCH and she has a flair for publications and she's written several books as well, and she's into in a big way into hospital administration as well.
Yeah, very good morning. I'm not going to show you something surgical, but something that definitely may influence the outcome of your surgery. So I'll be talking about the diurnal variation in intraocular pressure, also known as intraocular pressure phasing. So that's the day in the life of intraocular pressure, and what we see in our clinics is just a snapshot of intraocular pressure. What we really need to look at is an overall view of what's happening throughout the day with intraocular pressures.
Can you please restart the timer, please?
Yes, so that's what we see when we just take a single reading of intraocular pressure, and what we really need to look at is an overall view of what's happening throughout the day in the IOP profile of any patient. And this is very important for patients with NTG, for patients with ocular hypertension, preperimetric glaucomas, and pseudoexfoliation glaucomas. So when does IOP peak is something, the response is not yet concrete. There are several studies which say that there is an early morning peak. Others say that intraocular pressure is elevated at night, and others say that there is a steady increase throughout the day, and this varies for different forms of glaucoma and patients with different ethnicities. Now, these are the terms that are used by people who deal with intraocular pressure business. So what actually we are looking at is to find out what is the short-term and the long-term intraocular pressure fluctuation, because that's what gives us an idea as to how to maneuver our treatment profile. Now, there are several elements to an intraocular pressure. It's a dynamic thing. It's very individual. There is a 24-hour pattern to it, and there are off-hour peaks, and therefore we need to ascertain when the pressure rises in certain patients. Now, normally everybody would have a spike of about 6 millimeters of mercury when they wake up, and this dissipates by 12 minutes, and that's not the case in patients who have glaucoma. And most of the patients with glaucoma also have cataract. So once you do a cataract surgery in these glaucoma patients, where the intraocular pressure profile is variable, you are going to have a compromised intraocular pressure management post cataract surgery or post-trabeculectomy. So it's important to know about phasing in patients who are being planned up for surgery. Now there are several issues which pertain to phasing. One is the setting of measurements. We don't have typical sleep labs to a certain pressure profile. The type of tonometer that we use. Now we would be using a Goldman applanation tonometer usually in our clinics, but when it goes to a bedside examination, many would resort to another mode of checking intraocular pressure, which is the tonopen or the Perkins. Then the habitual body position is not maintained, and then there is availability of time when we are checking the pressures. Now the WGA, it states that there has to be a minimum of 4 readings for you to ascertain which patients are having a peak. 1 at 8 in the morning, then 12 noon, and 4 in the evening, and at 8 in the night. So you may not need to keep the patient in the ward. Even in clinical practice, when you're seeing the last patient of the day, you can see patients in which you want to check intraocular pressures. Now, diurnal intraocular pressure is not a fad for people who have residents and who have the facility to do it. Why it is important is that it helps you to figure out which patients are deteriorating on field and why. And especially in patients where there is an ischemic reperfusion injury, like the patients with NTG, it's important to do a diurnal intraocular pressure. Even on treatment, you may find that the patient is having 12 or 13 or 14 pressures, and still the visual fields are deteriorating, not up to what you would want to have. You need to check intraocular pressures even on treatment, because the intraocular pressure fluctuation should be less than 3 millimeters of mercury. Now this too has a bearing even after a trabeculectomy. Fluctuation spares no form of glaucoma, be it open angle glaucoma, normal tension glaucoma, PAC or PACG, all are affected in one way or the other. So it's very imperative that whenever you see that your patient is not behaving the way you would want it to, it's a good idea to check their intraocular pressure profile. This is something that we had done a while back. PACG was no different from POAG, and even primary angle closure patients who did not have frank glaucoma had intraocular pressure elevations. Now when we talk of NTG, that's something that many of us would be dealing, but we really don't know how to treat early or delayed NTG, and studies have shown that SLT, although it decreases the nocturnal IOP spikes, it's not as effective as a prostaglandin analog, and prostaglandin analogs are not as effective as trabeculectomy because it blunts both the diurnal and the nocturnal profile. So just a few case scenarios when to do phasing. This gentleman, 50-year-old, positive family history, the discs were good, the intraocular pressure was 24 and 26 on multiple occasions. Macular GCC showed early changes, but otherwise the OCT, RNFL and perimetry were normal. Now you would want to know whether you want to treat this patient or not. You do a phasing and you find out that the maximum pressures in the right eye are 32, in the left eye 24, and the minimum 24 with a difference of about 8. Now you categorize this patient as a high-risk ocular hypertensive, and since the pressures are going beyond 30 and the patient runs a risk of retinal vascular occlusions, you would know that you would like to treat such a patient. Another case scenario, a lady, 56-year-old, migraines, about 0.65 to 0.7 discs. Pressures are controlled seemingly 12 to 14 on a fixed dose combination of prostaglandin and timolol, but the visual fields have shown progression in the last 2 fields. You do phasing and you find out the pressure difference to be about 6 millimeters of mercury, and you know that you need to blunt out this fluctuation to about 3 or less, so you add another drug. So it gives you an answer and it helps you justify addition of a drug. You need to manage the F factor, that's the fluctuation factor, especially in pseudo-exfoliative patients, and especially now we being the diabetic capital of the world, many of our patients have coexistent diabetes. So it makes these patients prone to ischemic injury, and so in these patients also, if there is a labile profile, it makes sense to add another drug and titrate and explain to the patient regarding the compliance. Phasing post-surgery is also extremely relevant because there is a variability of post-op intraocular pressures, so sometimes you need to check pressures after the surgery. There are several logistics, but you really need to figure out what works best in your practice. There are now home tonometry devices like the eye care tonometer. You can give your tonometer to your patient, they check their intraocular pressure profile at home and bring it back. That's a one-time investment, costs about 2.75 lakhs, but it definitely gives you a better profile. There is an edge over a single day phasing. So you need to know what is the pattern of several days of IOP fluctuation for these patients. So in the end, I would like to say that intraocular pressure is not a static number. It fluctuates throughout 24 hours, and mean intraocular pressure is a strong predictor of glaucomatous damage. You need to sometimes ascertain intraocular pressure profiling for patients on treatment when they are getting worse, and many a times even after surgery when you haven't attained the desired results. Thank you very much for patient listening.
Thank you very much, Dr. Parul. Glaucoma continues to pose several questions to even the most well-known experts, and thank you for bringing out an important facet of glaucoma, which is intraocular pressure phasing. If there are any comments from the panel, we can have them, else we will move on to Dr. Rajiv Gupta's presentation on vitrectomy surgery in diabetic retinopathy. Is he here? Okay. It's a privilege and honor for me to welcome my dear Professor Amod Gupta, who was also the Dean of PGI Chandigarh. Welcome, sir, and we look forward to your talk shortly. Dr. Rajiv Gupta, I am told, unfortunately will not be presenting due to some unforeseen circumstances. May I now request Dr. G.S. Brar to please present his paper on phacoemulsification during cornea triple. Professor Brar, please.
Thank you very much, sir. I wish I were a professor. And I thank Dr. Ashok Sharma for having me here. I'm here to just reiterate a concept. It's not something new. Whenever we do a corneal triple procedure, essentially cataract surgery plus a penetrating keratoplasty. And after the cornea is removed, anybody who has done it realizes how difficult the cataract surgery is, because everything wants to come out, difficulty in every step, cortical removal, anterior capsulotomy, even the nucleus removal gets tricky. And then implanting a lens in the eye is a Herculean task at times. It just doesn't want to go in unless the intraocular pressure has been really, really well controlled. And a closed chamber technique like phacoemulsification, obviously the choice, provided the cornea allows it. As long as it is safe for the patient, it will be the preferred technique. I request you to just excuse a little bit of this quality issue with the video. It's a very old video. I just wanted to bring in the concept again. This is a fair, largely almost like a 5 to 6 millimeter leucomatous opacity with corneal adhesion as well. So just releasing those corneal adhesions and put in iris hooks to at least have a view beyond the corneal opacity. So here you see, I could at least see in half of the area some kind of a fundal glow. And here I could have stained the capsule, but sometimes that's like a double-edged sword. It actually kills the rest of the glow as well. So unless you don't have a red glow at all, there you will want to stain. Otherwise, you can actually do it without the stain. And people who do a rexis with the utratas can develop a kind of a feel to the rexis as well. And you can do it at times a little bit by feel and less with visibility. And you would want all your maneuvers to be in the part where you can actually see what you're doing. So you don't want to go, let's say, right in the middle, but slightly beyond the middle so that you can remove the nucleus like that. The saving grace here is you can pull stuff into the anterior chamber. You are not bothered about the corneal endothelium here, because the patient is going to undergo penetrating keratoplasty anyways. And the advantage obviously is you can implant the lens quite easily as you would do in a standard phaco, and the lens goes into the capsular bag. And after the lens has been placed in, you can make the pupil small by using pilocarpine, and makes the keratoplasty also much safer as far as the risk of no expulsive and other things is concerned. Now, the other situation would be where you have to do a lamellar corneal dissection to help you with the visibility. Again, not a new concept, but you will be surprised in some cases where you may think there is no way a phaco can be done. And a lamellar corneal dissection enables a closed chamber surgery, and vice versa as well. At times you think that a lamellar corneal dissection will help you quite a bit, but you are surprised that the visibility does not improve despite a lamellar dissection. So here was a case where initially you think there's no way phacoemulsification is possible here. So the first step was to do a lamellar dissection, and once the lamellar dissection was done, at least in the left part of the video that you see here, I could start seeing the nucleus a little, the lens a little. And mind you, the visibility here, what you see on the video is a little bit less. The visibility on the microscope was obviously better. And here, because there's no red glow, I stained the capsule. And again, the phaco is being done in the part where you have visibility. So, and the nucleus was slightly on the harder side, but the moment you have one crack, you can pull out stuff into the anterior chamber. You don't need to be close to the bag at all. And you can obviously, once the thing is done, implant the lens. That's not the difficult part. So I'll just conclude here. It's not something new, but the preferred modality. And always be ready for the conversion to an open sky technique. As long as you deem that it is safe for the patient in your hands, you can continue, and you don't need to go too much into the bag. The moment the rhexis is done and you have one crack, you know you can actually complete it. Thank you so much for your patience here.
Thank you very much, sir, for that excellent presentation. For those of us who may not know, which I feel there is nobody in this hall, Dr. Brar is in Sangam Netralaya at Mohali. Sir, you may not be a professor, but your talk was no less professorial. So excellent talk.
Thank you very much.
So, any comments from the Kanya people, Professor Jain, Harun Jain? No. Thank you so much, sir. We go to the last talk, last presentation of this session, which happens to be a short video by me. Can we have that video, please?
Training of ophthalmology residents is a crucial facet about which we can ill afford to be complacent or casual. For any slip-ups by the novice surgeon can be excruciating. Various animal eyes and virtual reality simulators suffer because of accessibility, costs, and lack of a natural tissue feel. Our model facilitates hand-eye coordination and learning fine motor skills, so pivotal for ophthalmic surgery. The exterior of the lemon is painted with adhesive, and fluffy cotton is stuck on to duplicate tenon capsule. An outermost envelope of mull fabric is stuck over the cotton to mimic conjunctiva. Gel transparent wax is heated and the molten foam is poured into the excavation to simulate clear cornea. These are then snugly fitted into the orbital margins of a face mask carved out of plaster of Paris. Fashioning a scleral tunnel incision and maneuvering the crescent knife and keratome at the limbal transition can be elegantly represented. Cellophane paper tightly wrapped around a clay or MCL tablet serves as substrate for practicing capsular hexis with cystotome or forceps, a vital step in cataract surgery. Grape skin or a boiled potato peel are fine too. Multiple attempts can be made as shown. Silicone rubber from a nipple can also be adapted as cornea and its flanges and nozzle bits used to design self-made intraocular lenses, as we shall soon see. Nucleus mobilization and vectis delivery can be practiced. Clear corneal entry incisions can be replicated on the gel cornea as it has a rubbery consistency. Nuclei removed during SICS come in handy for open sky in vitro maneuvers. Troughs made of M-seal and the core filled with colored sticky Maida dough into which the nucleus is embedded serves as the base of our anterior segment. Transparent lozenge blisters made of PVDC or polyvinylidene are used as cornea in this part. This is stuck on to the base to complete an artificial anterior chamber. Various steps of nucleus management in phacoemulsification can be demonstrated as shown. Initial dissection of conjunctiva and tenons and subsequent partial thickness scleral flap is portrayed here with a scleral block excision at the end as in trabeculectomy. Elastic bands can mirror extraocular muscles, and basic steps of resection and recession in squint surgery can be depicted as shown. Slinging of the recti for scleral buckling is demonstrated in this simulation. Subsequent steps of cryotherapy and suture placement for buckles and belt loops are characterized. The critical step of SRF drainage is facilitated by incorporating a glycerine-filled compressible water balloon into a lemon as seen here. Scleral cut down, diathermy to the lips, and choroidal tap to drain glycerine that resembles SRF are picturized. A lemon with a circular opening on top and with its contents eviscerated can be employed for rendition of various aspects of VR surgery. Fresh aloe vera gel has several biomechanical features of vitreous, and simple vitrectomy steps can be learned as symbolized here. Other procedures as shown can be attempted inside the cavity of the lemon. Trypan blue stain anterior lens capsule or blue kite paper can be employed for mirroring ILM peeling techniques. Both the lens capsule and ILM are made of type 4 collagen. To conclude, ours is a low-cost, go-green, indigenous depiction that should enable seamless transition of the greenhorn surgeon from the bench to the OR. It's a new way to make our first mistakes. Thank you for your patience.
A very rudimentary video, but now we have the simulators which have largely replaced. Can we have any discussions as the stage is getting ready for the inauguration? With regards to the previous paper by Dr. Brar, whenever we have been called upon in such cases, I have used a little indigenous vitreoretinal technique there. We put on a chandelier illumination, and that provides some amount of retroillumination which facilitates the steps in the anterior segment. So if you have a vitreoretinal colleague, he might just be of some help in that situation. Any other comments as the stage is being readied pertaining to any topic that we discussed?
I think Kumar, Professor Amod also appreciated your video, and really indigenous way of doing different surgeries on lemon and other things.
Thank you,
so
sir.
only question is, how does it differ from a goat's eye? Many people do and train residents on goat's eye, various procedures, especially cataract,
just that the availability, you'll have to go in search of these goat's eyes, and lemon is easily available, can largely be adapted, but the problem with both is both are perishable, so you'll have to each time keep getting new ones. Whereas now they are coming out with some specific material where they manufacture these things on a 3D printed model, and they're probably more akin to the normal eyes. But the biggest advantage of this is it's easily and freely available. And we need not, in fact, I had another video where, you know, the removed perfluorocarbon, instead of being discarded, can be kept aside, and that can be used for training in floating up nuclei and things like that. So that I had made a video of how to, the best out of waste. So for training purposes, the costly commodities like perfluorocarbon or removed silicon oil, etc., can be reused for training.
Yeah, really innovative. Good, nice.
Thank you, sir.
Wonderful, Dr. Kumar. After a long time I saw your this presentation. You expanded the inventory of the surgical procedures. Now, one question which I have, how much time does it take to prepare before anybody can train on? Preparation time for, you know, the modulus, whether for cataract surgery or corneal transplant or squint surgery, how much time does it approximately take for a person to prepare
for
artificial
each surgery? It will hardly take 15-20 minutes, and you just need to scoop out the lemon of all the inner flesh, and you only retain the ring. Whereas the cornea and the other things, as you saw, you just heat up that.
You can keep them in stock.
Keep them in stock.
Okay. Wonderful. I think it's
if the PGI people, sir, please go.
Yeah, PGI. I mean, every institute where they don't have simulators, because I don't think simulators are available beyond cataract surgery and the vitreous surgery. They're available for squint surgery or for trabeculectomy and, you know, pterygium surgery or passing Dacron sutures and stuff like that. I don't think ever they'll be available, but it's a great innovative techniques that you've developed.
Coming from you, I will take it with both hands.
I have always appreciated your innovative spirit, you know,
Thank you very much, sir.
You know, simulators and other stuff will come expensive. This is low cost, eco-friendly solutions, almost like if you had a microscope at home, it's a, you know,
Real life situation.
Real life, it's sitting at home, leisure time, you could be practicing all this.
If it can be suitably validated, then it will add more weight. We have a set of residents who practiced on these and then went on to surgery versus others who went on directly or some such, I don't know, you will be
yeah, you know, I think going directly to the, and that way, I am not sure people have done that kind of comparison. You know, absolutely greenhorn going on to patient surgery. Nobody would, you know, these days subject a patient to that kind of approach. You know, it will not be possible to do a trial. But the fear is all within the surgeon, the resident who's operating on, say, a lemon versus operating on a human eye.
True.
You know, that is what is, you know, the difference between, you can take analogy from the cricketers. One day when they're playing a Bangladesh or a weaker team, they're all heroes, they're all super, but the moment they face resistance, they all start...
Correct. It's the difference between a net practice versus a real match situation.
Match situation where you have all the stresses which come with the, you know, situation. So
probably that can never be surmounted.
That can't be surmounted, you know. That's, the confidence will certainly come from the definitive exposure to the patients. But to begin with, you know, I'm sure they could initiate this, or as a first year resident, first month they do all this peeling of the lemons and stuff, you know.
Thank you, sir.
Cost effective, very, very nice, innovative, yeah.
Thank you very much, sir.
Thank you.
We have the pleasant duty of beginning the inauguration of today's session. Dr. Ashok Sharma will say a couple of words before we move on.
Good morning, everybody. I would like to welcome and thank Padam Shiri Professor Amod Gupta, who introduced me to ophthalmology and nurtured my career. And also guest of honors, Padam Shiri Professor Jagatram and Dr. Emma Dogra, who shaped my career further. And I have been very well supported by Professor Pandav and Professor Suresh Gupta. I also thank CUS because this event is under the aegis of Chandigarh Ophthalmic Society. Both Professor Amit Gupta and Dr. Parul has been very supportive. I thank all my senior and junior colleagues who have supported all through my academic and my practice career. I welcome you all, and I now request President CUS, Dr. Professor Amit Gupta, to welcome the chief guest, Professor Amit.
Professor Amit Gupta is a professor at PGI Chandigarh and he is the president of Chandigarh Ophthalmic Society. Welcome, sir, and please do the honors.
Well, good morning, everyone, and I would like to congratulate Dr. Ashok Sharma on organizing such a academic feast and such an exciting event for everybody. And it is indeed a great pleasure to have Professor Amod Gupta, who's been my teacher, my mentor, and also Professor Jagatram and Professor Dogra, Dr. Arun Jain, and everybody who's here. I would like to welcome on behalf of the Chandigarh Ophthalmology Society. And we know that, you know, when we are dealing with patients, and science has its own way of how we deal with patients, but I think at somewhere down the line, ethics become more and more important. And I think I'm so excited by the topic of Professor Amod Gupta's talk, and that is crossroads of ethics and science. And I think we are at these crossroads sometimes every day in our clinics as we see patients. So, sir, I would like to formally welcome you to the event. And for the felicitation of Professor Amod Gupta, I would like to request Dr. Ashok Sharma and also Professor Jagatram, Dr. Dogra, and Dr. Suresh Gupta And sir, please come on stage. And Dr. Parul, who is the secretary, Chandigarh Ophthalmological Society, please come on stage for the felicitation, please.
Dr. Pandav as well.
Dr. Pandav as well. Sir,
please.
Please. Sir, please. So Professor Pandav is now currently the chief of the Advanced Eye Center at PGI Chandigarh. Welcome, sir. And I would like to invite Dr. Parul to felicitate the guests of honor, which is Professor Jagatram, please. So, Professor Emma Dogra. Professor S.S. Pandav, please. And Professor Suresh Gupta, who's the Chief of Medical Department of Ophthalmology, Medical College, Sector 32, Chandigarh.
Thank you.
Now I request Dr. K.S. Kumar to welcome and felicitate Professor Amit Gupta, President of CUS. Dr. K.S. Kumar, please.
After the felicitation, I have great pleasure in inviting all our esteemed invitees to kindly light the lamp, which is symbolic of our functions and asatoma sadgamaya. We will now have the national anthem. I request all of you to please stand by for the national anthem.
Jana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. The national anthem only concludes the inauguration function, so I request all of you not to go away. We have the whole day before us.
I request Professor Mugdha, our chief guest, to please honor our anchor, Dr. K.S. Kumar, please, sir.
I have the pleasant duty of introducing, and not introducing, of inviting Professor Amod Gupta to please deliver his talk. I'll just say a couple of words about Professor Amod Gupta. I know he doesn't like it, but I am very much inclined to say this. He's really been the pioneer of the Advanced Eye Center of PGI Chandigarh, and a paragon of virtues. By dint of his hard work and industry, he has inculcated the values of commitment, dedication in all of us. He has attained what he is, not his stature, not just by being a professional, but also by his nature. So he's a man of both stature and his nature, which all of us admire. Ladies and gentlemen, I present to you the inimitable and incomparable Professor Amod Gupta, the man for the ages. Professor Amod Gupta, please. He'll be talking on a very important subject which is not really directly related to ophthalmology. It is titled At the Crossroads of Ethics and Medicine and Science, which is probably more important than ophthalmology.
Well, thank you, Dr. Kumar and Dr. Sharma, for giving this opportunity for speaking to you this morning. The topic I have chosen for today's morning talk is, I see most of you are probably more innovators than scientists. And I'll be focusing on two people, by and large, in this talk. And before that, I'd like to remind you, many of you might have seen this picture from the famous Nuremberg trial at the conclusion of Second World War, where we have 23 defendants. 20 of these were physicians. 7 of them were hanged. And this trial, which lasted about less than a year, about 9 months, the recurring theme was violation of the Hippocratic Oath. First, do no harm. Now, these guys were trying to answer basic science questions. And just to give you an example, one of these was this, all this experimentation was done the Dachau concentration camp, where these experimentations were done. At least 30 experiments were discussed during the trial. One of them was how to cure hypothermia. And what was the strategy, the methodology used was to dunk the prisoners of war in cold water for varying duration of time to generate an exitus table. Exitus means the table of death. How long, at what temperature should a person be dipped, clothed or unclothed, into the cold water, and you can see the time of death in the last column, how much person would last. The data generated from this experiment was actually published. And it is generated, and not only from this experiment, but several other experiments that were done during the Nazi Germany. The debate was, many of these experiments and the data got either explicit or implicit endorsement by the number of citations they have continued to receive even 75 years subsequent to these experiments. The question of morality here is, should we use a data that has been generated from such torturous, inhuman experiments, or should it not be used? This led to, for the first time, development of the Nuremberg Code. This was the precursor of the Declaration of Helsinki, which was to follow almost like 20 years or 17 years later, which will establish the code of conduct for all the ethical conduct by all the physicians. The primary aim was that no experiment be done without the voluntary consent of the human subjects. It's absolutely essential. And there were several, at least 10 tenets in the Nuremberg trial, which was, and the degree of risk should never exceed the importance or humanitarian experience, importance of the experiment. So far so good. People did not believe around that time that it was important to take consent of the patient or person who was under your control, be hospitalized patient, inpatients, or prisoners of war or jail inmates, or who are under the control of an authority. Till this guy came on the picture, the Henry Beecher. In 1965, this guy, and this is 18 years after the Nuremberg Code, this guy started talking, going around the US, talking about inhuman experimentation which was done on patients. And he said, that the breach in the ethical conduct in experimentation are not rare, but are almost, one fears, universal. A year later, and he was called in the press the Henry Beecher the bombshell, because he dropped a bombshell on institutes like Harvard, like National Institute of Health, number of all the Ivy League hospitals and universities where people were doing, and people were scared because he named them. He named, this guy is doing this experiment, he's withholding penicillin, he's infecting patients with viral infections. So something of that kind was going on, and he was talking freely about these things, and people feared that if you name K.S. Kumar, he is liable to be criminally prosecuted. Something like that was the sense, fear, and that's why he was called a bombshell, Henry Beecher. So there's an era of ethical conduct before Henry Beecher, and after. Nobody was ready to publish his paper, which he managed to get, with much diluted, with 17 experiments, which he published in the New England Journal of Medicine, with the support of only the chief editor of that time. And they celebrated a couple of years ago the 50th, the golden jubilee of his paper was celebrated. Perhaps first time a silver jubilee or golden jubilee is celebrated. Around this time, somewhere in 64, the Declaration of Helsinki, why called Helsinki? Because the World Medical Association met in Helsinki in 64, where they established the code of conduct, and they came up with a number of tenets, which I'm not going to bother you with that, because all those tenets have become obsolete as of the last month. So this meeting, which happened only last month in October, is Declaration of Helsinki 2024, and first time they are calling these, instead of the term subjects, which they earlier called subjects who are undergoing any trials, they are calling them now participants. And there are several other innovations. They do admit that, well, human trials are required, essentially required for progress if we have to make in medical field. Now, all of you who are publishing papers, at least in the institutes, they always write, this adhere to the tenets of Declaration of Helsinki. And I'm sure 99% of the people who publish papers don't even read. So I have given you the reference to, this is the only valid reference for Declaration of Helsinki, and there are at least 37 tenets in this particular. Now, coming to ophthalmology, okay. Last year, an editorial appeared in Ophthalmology, the most prestigious ophthalmic journal. What are the considerations when we are offering? And this is tenet number 37 actually of Declaration of Helsinki 2024, that when we are offering minimally proven therapies or interventions, how should we be guided? And you'll be all surprised to know that the most revolutionary thing that happened in our lifetime was intraocular lens implant by Ridley. And it never underwent any proof of its efficacy or efficiency. So was Avastin. Use of Avastin became worldwide, it was used, but it never underwent any trials for its efficacy. On the other hand, the use of stem cells for ARMD ended up in disasters. Even ocular massage for central retinal artery occlusion, I mean, people have done that. It had no risk actually, but there was hardly any evidence for doing that. Or optic nerve decompression. People were doing at one point of time, they were reporting optic nerve decompression for non-arteritic anti-ischemic optic neuropathy. Disastrous. So, macular hole surgery. It is unbelievable that macular hole could be closed when it was proposed. So these are some of the examples of innovative surgical procedures which became or which were accepted without any. So there is a place for innovation, Dr. Kumar. There is a scope for innovation, and the Helsinki Declaration admits to that extent, well, there is a scope for doing that. Now I'll give you the examples which pertain to us. Long time back, Dr. Richard Green, one of the most famous ocular pathologists, had established pathology of the branch retinal vein occlusion, and he showed, well, there is a thrombus which forms and starts getting organized within hours of the occlusion taking place in the vein, okay? And, it gets canalized spontaneously or it remains thrombosed. So these are two things that may happen. Either it will remain thrombosed, organized, or it will get canalized. And there may be a single channel or multiple channel. And he also showed that through his pathological studies that arteries and veins at the crossing, they share a common adventitial sheath. So this paper came in 1982. And 1988, and those of you who are retinal surgeon, Dr. Dogra here, Steve Charles, last month during the American Academy, he delivered the biggest oration, the Robert McNamara lecture. Same Steve Charles, who has, I think to his credit, the maximum number of innovations in vitreous surgery. What did he do? He reported that, well, he did vitreous surgery and used a curved scissors to dissect and relieve the artery from the vein. To his credit, he did some experiments on the porcelain eyes, on eye bank eyes, also on some of the unoperable human eyes, where he put his scissors and tried to cut the artery or separate the artery from the vein. He feared that there will be complications, there will be retinal tears, there will be hemorrhage, there will be retinal detachment, and he was fully aware of the paper because he cites that paper of Dr. Richard Green. He did not understand what he said in that paper. He read it, cited it, but probably didn't understand. Now, all was good. And this paper was obviously, lapped up by the retinal surgeons, and everybody started doing this procedure. Until this guy, I'm sure Dr. Dogra would have heard of this Oprimchak guy. He is actor number 1. He reported that he has successfully done a decompression of the branch retinal vein occlusion via arteriovenous sheathotomy. So he says, well, I dissected out and I reperfused the retina in a patient of branch retinal vein occlusion. And you can see the massive number of attention from the academic circles he received for this. So Oprimchak, remember this name, actor number 1. And over the next several years, it received so many papers, so many citations, and spawned uncontrolled trials for a number of years. Till this guy comes, Dennis Han, and he says it cannot be separated. The artery cannot be separated at the crossing with any technique, and it ends up with a disaster if you try to cut the artery from the vein. So there's no way you can actually do it. And you can see this paper, any paper with a negative outcome is hardly noticed in the academic circles, and that was the case here. And here is Dr. Dogra's friend, and this video I'm playing with his permission. Actually, Mark Hamayun, again a very big name in retinal surgery and innovations, the first time he produced the bionic eye, he said, let's not do vitreous surgery, let's use a small spatula agent created 25 gauge without vitreous surgery. He said, let's manipulate the artery and the vein, and he says it restores the, good for him. This did not receive any attention. He published another paper the same year in BJO, where he presented the results of these 12 eyes where he had done the LAM procedures. I believe nobody ever in the world did this procedure ever again. Now this guy comes, Chung, in 2008, and he says whether you inject intravitreal triamcinolone or you do AV sheathotomy, it makes no difference to the functional and anatomical outcome. Structural outcome is the same. So it was useless trying to do vitreous surgery and do arteriovenous sheathotomy. And this guy, he says the outcome of vitreous surgery with or without sheathotomy. Now he is comparing two. Just do a vitreous surgery or do a sheathotomy, it makes no difference. Okay, so whatever the Oppencheck got the popularity, became well-known name all over. I think he was lecturing around the world, talking nonsense, because these things was not plausible. It was not validated by controlled trials, and when people attempted to do that validate, it failed on the test. Now enters the actor number 2. Can we switch off the light, please? Switch off the lights. This is Geoffrey Weiss. And Geoffrey Weiss had, let me do something with the central retinal vein occlusion, and he used a micromanipulator to inject TPA, tissue plasminogen activator. It was very popular at the time for coronary artery disease that patients were given TPA intravenously to lyse the thrombus. He first published a couple of reports, and then he went on to a larger series, but soon he realized within 4 or 5 years that probably it's not working, so he started injecting triamcinolone acetonide. We know triamcinolone works on its own without the help of thrombolysis. Now this was immediately contested by Dr. Harry, that this fellow has no clue how thrombolysis works, and he says thrombolytic treatment is effective only within hours of the thrombus formation and never after weeks or months or years later. So that doesn't work that way. Secondly, when you are flushing fluid, it will go through any of the multiple channels that are available for the central retinal vein. Central retinal vein is not a single channel, but it could be multiple channels, and it will not necessarily go through the thrombosed vein, it will go through the least resistance path. And so it was junked. A German scientist said he tried to do it thrombolysis in ischemic central retinal vein occlusion, and he ended up with disasters. He said, my patients got neovascular glaucoma, the eyes had to be enucleated, a number of surgical procedures, more than the number of eyes you can see, they had to undergo. And he published results in ophthalmology. And now Geoffrey Weiss writes a letter to the editor that this fellow is foolish, he doesn't know how to do this microcannulation and is bunkum, this result should be discredited. And he said, these are inexperienced people, so it should not be okay. But of course, the author said, we are very well experienced surgeons. Now we come back to the first actor, Oppencheck. Now he is the guy you have seen earlier who popularized, I would say, arteriovenous thotomy for branch lateral vein occlusion. Now he's turned his attention to central lateral vein occlusion, and he said, let's do radial optic neurotomy, because let's cut the scleral, outer scleral, compartment. He said, it's a compartment syndrome. He didn't know, not only he didn't know the pathology of the central lateral vein occlusion, he also did not know the anatomy of the, you can see the schematic given by him. He didn't know the anatomy. So this is not an elastic scleral outlet, it's a fibrosis, and there are multiple channels. And he was doing this in the nasal side of the optic disc, and without realizing that you are cutting off, and he said, no, no, you can cut the arterial supply, circle of Zinn, you cut the arterial supply, it doesn't do any harm. And I'm sure people in Chandigarh were doing this procedure. Fortunately, we didn't take up this procedure in the PGI. And then people started reported complications. They say no light perception, hemorrhages, and there's no way it was not a plausible surgical procedure, but he got this guy, Geoffrey Weiss, the operum check, a lot of publicity and a lot of citation, 295 citations. Imagine how much popularity he got world over for this procedure. Again, it was labeled illogical and was challenged. And as I told you, there's a number of complications. Now look at the journals. The procedure has been called out in 2007, and they kept publishing the papers, all prestigious journals, British Journal, American Journal, Archives. They were all publishing the reports. The editors not applying their mind that this was a logical procedure. So what we learned from this, that before you adopt a new innovative technique, you must look very carefully at the plausibility. Is it plausible? Look at the pathomechanism, methodology, bias, power of study, safety. All these issues need to be taken into. But the important lesson is, you can't cite that this technique is published in a paper. Look, it has hundreds of citations, because that does not translate into standard of care. Multitude of papers on a technique is not a validation. I'm sure some of you would be surprised at hearing this statement from me, but I have shown you the proof. Why it happens, why so many people take over? They're all looking for, the editors are looking for innovative techniques, breaking news, as you know, that they want to publish breaking news. That this is, me first. I published it first in my journal. And rest follow like sheep. We all have sheep-like behavior. Somebody done some procedure, we start doing it without thinking of the concept. No, that has been published in ophthalmology in American Journal. How can it be wrong? No. I'll just, if Kumar gives me time for a couple of minutes, I'll talk about the stem cell therapy, which became very, very popular around the same time. So I like to recall this guy, Geoffrey Weiss. He was the one who used that cannulation, and he claimed in 2008, he made public claims, look, I have done 450 procedures of microcannulation and thrombolysis of central lateral vein occlusion. You can imagine the kind of publicity he had garnered in the US. World over patients are coming for getting the procedure done. Now he comes with, now he knows that the stem cell were a big thing around that time, 10 years ago, and he started injecting stem cells taken from the bone marrow, mesenchymal stem cells. He had another colleague of his, Stephen Levy, with whom he started kind of a research group, two-man research group. He registered this clinical trial on the American website, and he offered stem cell therapy for, and this is the data I have taken, this is from the site of the clinical trials.gov, which is the American clinical registry for the trial, and he said he could treat anything, and this is a list of the diseases for which he was doing stem cell transplant, which includes, if you see carefully, blindness, visual loss, night, visual loss partial, vision low, retinopathy, maculopathy, retinal atrophy, and all. He listed all that came to his mind. This is a government site, imagine. And what did he do? He hoodwinked not only the government clinical trial site, but he hoodwinked the people by claiming that I have an institutional review board which has approved this therapy. My research is listed on this clinicaltrials.gov, okay, and I have published work. We have published our results, and it is patient funded. So he was charging $20,000 and he called it patient funded trials. He had first, he never reported those results, SCOTS 1, then came SCOTS 2. Again, people sitting in that portal, you know, clinicaltrial.gov, were probably blind. They did not see through the game how he was exploiting, and published in a number of papers in predatory journals, which we call the fake journals. And, you know, he claimed that I could treat Stargardt's disease, okay, by giving stem cell transplant. So you might be wondering, why do I bring all this issue here? It doesn't matter. In India, in Indian setting, you would be surprised to know some of the biggest institutes of this country were doing something similar. They were either injecting retinal pigment epithelial cells or stem cells, mesenchymal stem cells drawn from the bone marrow, and they were injecting into the patient's eyes for doing all this kind of research. Now, how was it exposed? And this guy, one of the authors, Thomas Albini, happened to be a friend. He published a report in New England Journal of Medicine, and when anything gets published in New England Journal of Medicine, it becomes news in US world over. They published 3 patients who received for AMD bilateral stem cells, and all the 3 patients went blind, so they reported 3 patients. Immediately the antennas went up, and because it made news headlines in the New York Times when this report came, that somebody, and it seemed there were several scores of these centers which had come up in small towns, and this was in southern Florida, that this kind of, you know, people were being made fool, and they were charging so heavily. So FDA issues a warning about the use of stem cell transplant for that it's illegal, and they would be jailed if they did it. Then the American Medical Association came up with a statement. I have just given you the abstract, because people who do not have any approved therapies or ineffective therapies, and not only life-threatening situations, but also sight-threatening situations like retinitis pigmentosa, optic atrophy, and there are a number of patients who, you know, are vulnerable to all these scamsters that operate around within our own community, you know, who want to become as popular as Jeffrey Weiss or Jack or coming out with those techniques. Not only that, last year BBC did a story on Jeffrey Weiss. The person who did the reporter, Ramadan Yunus, himself suffered from retinitis pigmentosa, and he went to him and exposed the scandal, as they say. And he said, he was surprised. How come in such a highly regulated country like US, this guy could be fooling the people, making millions of dollars? And then what action was taken against this man? And he reports that in 2021, the American Academy of Ophthalmology took away his membership. He has run away from US, and now he is speculated to be operating somewhere in Middle East, and maybe it turns up in some small town in India or Pakistan or Bangladesh one day and start fleecing the patients, I'll not be really surprised. So what is the carry-home message? Again, I like to emphasize that when you publish, when you see a paper in high-impact journal, or these extensively cited papers are no guarantee they are standard of care. You have to be beware of deceptive, misleading, innovative therapies. So anybody uses the word innovative, your antenna should go up. Is it plausible? Is it validated? Is it safe? Is it effective? You know, the editors I told you, they fall into a trap of me first. I am talking not of editor of Indian Journal of Ophthalmology or Chandigarh Newsline. I am talking of ophthalmology, American Journal, British Journal, Griffiths Archive, all the highest cited journals, even their editors fall into the trap. I have just given, for the in interest of time, just given you a few examples, and I could be talking about this subject the whole day. There are so many examples of trials which had been done. Patients had been blinded. These papers get cited because majority of us, the minority is innovators, majority are like sheep. We want to be seen immediately following that. You don't want to be seen outdated in your practice. You want to immediately latch on to a new innovative technique. So my message to you is, please think for yourself before you start practicing any innovative sounding technique or therapy, unless you wish to be hanged one day like the Nazi Germans were hanged without a second thought for those kind of experiments on humans. Thank you very much for the opportunity.
How did the audience read my mind? I was just about to say that Professor Amod deserves something more than a standing ovation. I am ready for a jumping ovation if there is something like that, but many of you may not be willing to. We will stick to the standing ovation. We all know that he is a man who eats, sleeps and drinks ophthalmology. I just want to narrate 2-3 facets that I experienced as a junior resident, even though it may take a little time. When I was a second year junior resident and I was going home, I had a call from the nephrology department to see a patient, and those days we were not well versed with the indirect, so I saw the patient with the direct ophthalmoscope, and somehow I had seen a similar figure in Bailey and Lowe's general surgery stating that it is like CME retinitis. So sir was going home late. He used to be the last one to leave the department as always. So I was just walking back, and then I saw him going home with his briefcase and said, "Sir, I have a case here. He's sitting on the bench and it looks like a CME retinitis." He took the direct ophthalmoscope from me, had a look, and then he said, he was humble enough to admit that, "Yaar, mujhe pata nahi hai. Ye lagta to hai. Let us check tomorrow." And he got him to the outpatient, did a fluorescein angiogram and looked at the fundus. And he frankly said, "This is probably the first CME retinitis of our case," and we presented this in the 1991 All India Conference as a poster. So just look at the humility of them. He was already additional professor at that time. On another instance, he came to Bangalore and I was just having a moped with me. And he had a little spare time, so we went around the city and he sat at the back of my Luna. Though I said, "We'll take a taxi," he said no, and he sat on the back of the Luna. Such is the humility of the man. So the taller he has grown, the lower he bends. So we all need to learn from that. He was very hesitant to come today because he said he wants to recede. But sir, there is a book which is titled differently, but I have rephrased the title of the book as "Quit Empty." The title of the book is something different. So you are, by all means, we will allow you to recede, but only when you are empty of all your knowledge. You will never be empty of delivering all your knowledge, so you can't quit. So we need your services for all time to come. And thank you so much, sir, for that excellent lecture. So all work and no play will make Jack a dull boy. So we will now break for tea and then reassemble in 15 minutes time. May I have your kind attention, please? We should be reassembling to start the next session. Request all the delegates to kindly finish up with their coffee, tea, and please be seated. I repeat, I request all the delegates to kindly please be seated so as to start the next session. Thank you.
Bridwan.
Thank you very much for all those delegates who have come back. May I request the others who are still having their coffee to kindly come back as quickly as possible so that we may start the other session. In fact, we are going to start the next session. May I request Dr. Jagatram, Professor Dogra, I think, is he going now, sir? Ashok Sharma ji? Professor Dogra is leaving? He has left, okay. Professor Amit Gupta, Dr. G.S. Dami, Dr. P.S. Brar, Dr. Jagdeep Basur, Dr. Gaurav Sharma, and Dr. Rajiv Mircha and Dr. R.K. Bansal to kindly come over as chairpersons for the next session. We have titled this session as Front Office Matters because this is mainly concerned with elements of anterior segment. I call Professor Dr. G.S. Dami to begin this session. He will be speaking on phaco in previously RK operated eyes, which is a unique topic. Dr. G.S. Dami, please.
Thank you, Dr. Kumar. Thanks, Dr. Ashok, for letting me be here, and the Chandigarh Ophthalmic Society. It's a pleasure to be here always. Giving farewell to good morning, good afternoon, everyone. May I have my video, please? Well, this is the most common thing of the day we are going to come across. So many people operated with RK. Let's see how we proceed. The video has audio itself.
Managing the tough RK.
Audio, please.
We present a case of 55-year-old male presented for routine cataract surgery with a history of radial keratectomy done 24 years ago. The patient had 24 corneal cuts with an axial length of 30 millimeters in both eyes and an IOL power of 11.5 diopter in either eye. We present our learning and a different approach in either eye, which alters our final outcome. The first case is being done under topical anesthesia, which follows our routine steps for phacoemulsification, starting up by making the limbal-based incisions in between each of corneal cuts. Following which, anterior capsulotomy and hydrodissection are done. But just as we insert the phaco probe, the old corneal incision gives away. We suture it and proceed ahead with the surgery, but it adds to a lot of chamber instability. And in the end, all goes well, but suturing the wounds in modern cataract practices is disheartening. Let's learn from our mistakes. This is the other eye of the same patient. The changes we made for this case are: we gave a medial canthus block to obtain analgesia. We made scleral incisions for our side ports and our main incision as it eases the pressure on the previous corneal cuts. We are able to perform the phacoemulsification and nucleus removal without the trouble of reopening the RK incisions and without any need for wound suture. IOL insertion and stromal hydration is followed through. Conclusion. In the end, it's a learning experience to perform either a Suntanen or medial canthal parabulbar block in high myopes, which prevents any chances of globe perforation. To plan scleral-based incisions to allow for easier maneuverability and prevent leaky wounds. 52-year young man who underwent radial keratotomy 30 years back and now has come for cataract surgery. He has got pathological myopia in both the eyes. He also happens to have a macular pathology, so visual prognosis is of course poor. Planning a cataract surgery in eye who have undergone previous RK is a challenge. Let's move on to surgery. Let's begin the surgery. It is being performed under topical anesthesia augmented by medial canthal block if required. The major intraoperative concern is these cuts don't give away. This is a 16-cut RK. The areas of incisions are marked as two side ports in the main incision. These incisions are placed in between the cut, a little on the scleral side. Air is introduced into the eye followed by intracameral lignocaine, then staining the anterior capsule with trepan blue. The chamber is pressurized with dispersive OVD in time to perform the main incision. We again prefer a scleral incision. A gentle hydrodelimination followed by hydrodissection is performed. A gentle burp of the OVD is must before this step. The nucleus is decompressed and the nucleus rotation is confirmed. The nucleus is on the softer side. The fundamental principles we use in this case is a low infusion pressure, which prevents the cuts from giving way to low parameters. Surgery is planned in all steps of phacoemulsifications. The superficial cortex is being aspirated out, followed by hydroprolapse of the nucleus, and use phacosalute technique to emulsify the nucleus using minimal power. The chamber is refilled with viscoelastic repeatedly. The AP nucleus is rotated with a blunt lens manipulator. Hydroinsertion. The bag is filled with OVD and IOL insertion done gently. An OVD in front and behind the lens is removed thoroughly. Conclusion. Never intersect the RK incisions. Prefer a scleral tunnel for main incision. Low parameters in phaco settings preferred. Avoid overhydration incisions. Avoid multifocal IOLs. Post-operative cornea is flatter than expected. Repeat refraction after 3 months. There is diurnal variations in refraction.
And the only thing I would like to pass a message, please do convey to the patient, the previous surgeon did an excellent surgery, but that was the only available then. Never say RK was a bad, but it was then the best. You have to handle it now. Thank you.
Thank you very much, sir, for drawing our attention to a unique clinical situation and enlightening us about several bottlenecks in the management of patients with RK. In fact, when I was trying to understand, because I am not familiar with the stalwarts in this part of the world, so Ashok Sharma did introduce me as to me as a prolific cataract surgeon and a roaring practitioner whose roar can be heard in all of Punjab and neighboring Haryana, and you had a roaring presentation as well. Thank you so much, sir. I request Professor Jagatram to kindly felicitate Dr. G.S. Dhami, please.
Thank you. Thanks.
May I now request Dr. G.S. Mangat to please talk to us on SMILE, his initial experiences.
Good morning, everybody. Thank you, Dr. Ashok Sharma and Dr. Rajan Sharma, for inviting me for 3rd Chandigarh Eye Film Festival. So my talk is not only to SMILE, my initial experience. So SMILE is a preferred option nowadays. Reason is super precision, biomechanical stability, better ocular surface, and we avoid complication related to flap. Surgical technique, there are 4 basic parts: docking, femtosecond laser application, lenticle dissection, lenticle extraction. And first 2 steps are the easy, whosoever do the LASIK surgery. Now, lenticle refractive procedure has steep learning curve because dissection and extraction is really challenging for beginners. So it should be a stepwise approach. Observation of the senior doctors, surgical video, you go through literature, publication, wet lab training is must. You go through for minimum 5 cases for to familiar with the lenticle dissection, lenticle extraction. And for the beginners, case selection is very important. Avoid low myopia because you need a little bit thick lenticle to handle a better way. and then deep-seated eye, narrow pupil fissure, prominent nose, extremely anxious and high astagle. So these are, I'm not going detail, intraoperative completion, suction loss, black spots, OBL, capsule lenticular adhesion, retained lenticule, cap tear and side cut. And these are the signs, meniscus sign described very well by Titial to know the anterior lamellar space and posterior lamellar space, the shimmer sign and white ring sign, which helps you identify lenticule, anterior and posterior plane. So, video please. No, sorry. Video. Yeah, now this is a docking and laser applications, not a problem. You just ask the patient to look into the central light, and it's a very fast, it's a low vacuum machine. I'm talking about the Visumax 800. Now the main challenge is to first you open the cap side cut, then identify, to just separate the cap and anterior surface of lenticule. Once you identified the plane, you enter in the anterior lamellar plane, dissect slowly, slowly, go up to the outer ring. Then after separating lenticule from the cap, then you separate the posterior lamellar plane from the stroma, and after dissecting fully, just with the micro forceps, you hold the lenticule and never pull direct, never put direct force, always in circumferential. And these are the parameters not very visible. This this procedure takes just 9 seconds. Total vacuum is 15. This is the second eye. So I asked my application specialist, now I can do independently. This is my third case basically. So here is a misdissection. You can see clear cut. There is meniscus sign, so I entered posterior plane instead of anterior plane. And in the second time also I am in the posterior plane. So ideally one should dissect anterior plane first, otherwise you are having a difficult situation. So I am trying to go into the anterior plane, but inadvertently I again enter in the posterior. You can see clearly I am dissecting posterior. You can see white line clearly on my instrument. It shows that I am in the posterior plane. Ideally I should do first anterior plane dissection, but I could not realize, because it's initial cases you always do. This is a common problem, happens in beginning. I'm trying to find posterior plane, but I already, there's no force, it means this is a posterior plane. Then I try to separate, dislodge the capsule, lenticule from the anterior cap. You can use Sinski hook also, and again I'm trying to enter, but then I realize okay, I'm again and again I'm separating only posterior. Then I try to find the anterior plane once again. So I could little dislodge the separation little bit, not fully. So, yeah, this is slightly separate from the cap, but not fully. Now I'm trying to grab with micro forceps, and you just hold the eye, otherwise there's a chances of tear formation if patient moves your eye, his eye too. I'm trying to grab and pulling, but there's a thick adhesion, and so you can see the strain line. And because of handling, there is my radial tear also. Then I change my instrument. It is simple McPherson forceps, and try to grab and circumferentially, without much damage, and the full lenticle I could extract from the. So this is a learning curve. It is, you must do some cases under application expert. Thank you, sir.
Thank you very much, sir, for that excellent presentation with good videos. May I request Professor Pandav to kindly felicitate Dr. Mangat, please. Dr. Mangat, as we all know, is in Sohana Hospital at Sri Guru Harkishan Charitable Hospital and is a prolific cataract and refractive surgeon. Cometh the hour, cometh the man, they say. So we now have the star of today's show, the kingpin of the whole program, Dr. Ashok Sharma, who will be talking to us on pediatric corneal transplant. He has carved a niche for himself in the small subspecialty of pediatric corneal transplant, which is no mean task. He will be talking on overcoming challenges and optimizing outcomes. Dr. Ashok Sharma, please.
Good morning, everybody. I will be speaking and sharing my experience of performing pediatric corneal transplants. Pediatric corneal transplant is a difficult proposition, but if you continue to perform, you continue to improve, and you continue to take challenges, and that's how you can build up your experience, and you can like improve your results. It's a different ball game, and the challenges are also different compared to the adults. Audio, please. We have congenital indications, and we know that the prognosis in congenital indications are poor because of associated congenital anomalies. In comparison to congenital problems, in acquired problems, the results are better because the children who are operated are of older age, and they have at least seen during their life, initial life. So we need comprehensive evaluation, and we need investigations and sometimes special investigation to ascertain the visual prognosis. Can I stop here and start video only, because they recorded video basically? Just play the video only.
The authors present measures to optimize the outcome of pediatric keratoplasty in infants and children. To perform corneal transplants in infants is a Herculean task. A number of challenges make this proposition difficult. The authors have performed 213 corneal transplants in 178 children, the youngest 2 months old. Infants and children are at higher risk of rejection. Congenital indications pose more difficulties and carry less favorable outcomes. Children with acquired conditions are older, have already seen, and have a better prognosis. Preoperative comprehensive evaluation is essential. Various imaging and electrophysiological tests are done to ascertain visual potential. Surgery should be performed as early as possible, and an eye with a better prognosis should be performed first. Parents counseling so that they have realistic expectations is of paramount importance. Infantile glaucoma with corneal opacity poses special problem. The first infant aged 7 months had bilaterally operated infantile glaucoma and opaque cornea. One can see the bleb area and dense corneal opacity. It is important to measure the corneal diameter and mark the center of the cornea. The corneal diameter was 13.5 millimeters, and an 8.0 millimeters diameter corneal trephine was selected for host corneal trephination. A trephine mark was obtained. Partial thickness trephination was done. An anterior chamber was entered and sodium hyaluronate was injected into the anterior chamber. The host cornea was excised using corneal scissors. Due to appropriate preoperative measures, the intraoperative pressure was normal. We have used donor cornea with 3654 cells per mm squared. The donor was sutured using interrupted 10-0 nylon sutures. The first 2 cardinal sutures were placed 180 degrees apart. Then 2 sutures were placed at 90 degrees to the first 2 sutures. Suturing was successfully completed. The graft is clear and the child is enjoying good vision at 3 years follow-up. Infants operated for corneal opacity with infantile glaucoma have clear grafts. The youngest one operated at 2 months of age. Positive pressure is a major challenge. We use all measures to prevent positive pressure during surgery. The second child had severe congenital ocular dysgenesis. They had microophthalmia, microcornea, and sclerocornea. The corneal diameter was 8.5 and 8.0 millimeters. A 6.0 millimeters corneal trephine was selected and partial corneal trephination was done. The anterior chamber was entered and the host cornea was excised. The child had been given intravenous mannitol and hyperventilated, therefore we did not encounter intraoperative positive pressure. The donor corneal button 0, 5 mm oversized was sutured using 10-0 nylon interrupted sutures. The child underwent surgery in the left eye 5 months later. She had one episode of graft rejection that was successfully treated. The child has started going to school and is able to read and play with her friends. She is able to take part in extracurricular activities. There are many success stories similar to these. Children have clear grafts during follow-up. More than 50% of children had more than 660 vision. We always prefer DALK when possible. Penetrating keratoplasty remains the gold standard and carries favorable outcomes with monitored follow-up.
Thank you very much for patience.
Thank you.
Excellent presentation, Dr. Ashok Sharma. When that was an excellent series by Dr. Ashok Sharma. When most people would give up or despise corneal transplants in the young as intimidating and thankless, Dr. Ashok Sharma has shown how it can be very gratifying. It's virtually like taking the bull by the horns, and he has really shown massive success with his endeavors. He was one of my senior residents when I was a junior resident, and he had a special soft corner for me. He used to scold all the other junior residents, but he somehow had a soft corner for me and continues to have the soft corner even now. I have great pleasure in, though he is the host, I am the host now in this particular instance, that I'm very happy to felicitate Dr. Ashok Sharma. I now have the pleasure of inviting Dr. Prafulla Maharana. He is Associate Professor in RPC and Secretary of DOS, and I have seen him conduct several quiz programs in the All India Ophthalmic Society. He will be talking to us on treatment of dry eye, what, when, and why. The 3 W's.
Okay. Thank you, Ashok Sharma sir, and Chandigarh Ophthalmic Society for inviting me here. So my topic today that I am going to cover is when you are treating a patient of dry eye, which lubricant you should use or you should choose. So why this is important? Because in India we don't collect data, but this is a data from USA, and you will be amazed by knowing the amount of money that is being spent per year just for lubricating eye drop by the patient. So this is the amount that in USA people spend over 1 year. So it has a lot of implication to the patients as well as the pharma companies. You can see all this flyer, most of them are lubricating only. So that is the implication of to know which lubricating drops should you use. Because if you go to the market, you will get 100 drops, and all of them are nowadays like ORS medications. They give you energy, they give you electrolyte, they give you everything. But all the drops are not suitable for all types of dry eye. So how to choose? So for that, little bit basics, what does they contain? So as you can see in this picture, the main component is a demulcent, which is a hydrogel most of the time. Then some ingredients are added to that to have some special functions. I'll go through that one by one. So this is what I told you. They may have preservative, they have antioxidant, there are some oily agent, there are osmoprotectants, electrolytes. Everything can be added to some hydrogel to prepare a teardrop. So these are the 2 important properties that you should know. Demulcent, that is a universal component of any dry eye. It's just like a toffee or chocolate that we used to have when we used to be kid. It gives you slimy coverage over the epithelium, corneal epithelium. So that prevents the cornea from drying. But another property is humectant. What does it do? Once you put a demulcent, then it may dry up over a period of time. So if you add something called humectant, then that will absorb the moisture, surrounding moisture. So the amount of dryness that can be controlled may be little bit prolonged. So these are the basic two properties of almost all the lubricating drops that are available in market. So if I compare these four agents, most of the time we either use CMC, HPMC or sodium hyaluronate or polyethylene glycol. So if you see this table, CMC with which we all are comfortable, it has mucoadhesive properties, right? But if you go to HPMC, it has mucoadhesive property plus some water absorbing properties. Then you go to polyethylene glycol, polyvinyl alcohol, HP guar or glycerin. They do have these two properties, but in addition to that, they have some lipid restoration properties also. And then comes sodium hyaluronate. In addition to all these properties, it has some role in epithelial healing also. So these four properties and four group you should remember while treating a patient of dry eye. Then there are some special properties, as I said, like osmoprotectants, which primarily you might have come across people popularizing trehalose, glycerin, sorbitol. So what they do is they basically reduce the osmolality. Osmolality is a main culprit in dry eye pathogenesis. It induces inflammation and leads to surface damage. So they can control that. In addition to that, as you have heard, people are trying trehalose now in keratoconus. Why? Because they reduce matrix metalloproteinase synthesis also and reduce the oxidative stress. So whenever you feel your patient is having some hyperosmolality, because nowadays kits are even available, you can choose any drop with these ingredients in that. Antioxidant vitamin D, yes, people have come up with the hypothesis that there may be some oxidative mediated damage also. So that's why you can use antioxidants in your tear drops. And vitamin D, a lot of research is going on. So this you can include if your patient is, you can see there are punctate stains or conjunctiva staining is there. You can see epithelial damage is going on. So if you use a drop that has these properties, that may be helpful. Then some formulation, they have this oil-based formulations, mostly in the form of liposomes or nanoparticles. So these are specially useful for MGD. Whenever you think that your patient is having a dry eye, which is lipid deficient dry eye, try to choose a lubricating eye drops with these properties. Osmolarity electrolytes, they basically supplement the aqueous layer. So if you feel your patient is aqueous deficit dry eye patient, then in those patients it's better to choose some tear formulation which have some electrolytes added to that. Preservative, yes, these are definitely there in almost all tear drops available in India, barring few. And always remember, having preservative is not a crime. As most of the companies, they will claim we have preservative free, but preservative do damage the ocular surface the moment the frequency of eye drops goes up. So if your patient requires 4 times a day tear drop, there is no harm in going for a drop which has some preservatives. But if the frequency is more than that, it's always better to prefer some preservative free drops or some soft preservatives. Soft preservative means once they reach the corneal surface, they will break down into byproducts, and the preservative part which in most cases is benzalkonium chloride, those toxic effects will not be there at all. So those nowadays soft preservatives are quite common in most of the tear drop that we are using. So with this, I'll come to this slide because so this slide is important because this is how you can choose. First focus on this part, right? So if you feel that your tear film, your dry eye patient is primarily lipid layer deficient dry eye, go for something oily agents, right? If the problem lies is aqueous layer, the best example is Jogren. Okay, so there if you just need to resupplement your tear film, you can use any viscosity enhancing agents, which can be CMC, sodium hyaluronate, anything like that, with added electrolyte. But you are expecting some damage to your mucin layer. Then in addition to viscosity enhancing agent, you can use some other formulation which has some added properties like that. But if you notice your epithelium is already getting damaged by seeing SPKs, intense inflammation, conjunctival staining, all this thing, Then in addition to this property, you need either antioxidant or some cytoprotective agent like trehalose. So this looks quite simple, but if you see on this side, most of the teardrop, they have overlapping properties. So some teardrop which are effective in healing epithelium, they will be effective in mucin layer deficiency also. Some which are effective in lipid layer protection, they will be effective in aqueous layer deficiency also. So there is a lot of overlap. However, the basic principle remains this. You should remember this, and this is how you should choose. Now, this is the treatment algorithm. I am not going into this. So this is a simple clinical grading system, although it's not standardized, that we follow. And we divide dry eye patients not based on that IDUCE criteria, because that is too complex. In OPD you are sitting, and if a patient comes to you, just categorize it as level 1 if the patient just have symptoms and you don't find any signs on TBUT or Sharma test or any bedside test. Then in those cases, any drops including CMC would work. If it is level 2 means patient is having symptoms and you are doing slit lamp test like Sharma or TBUT, and there are some abnormality in the test, but it's not too much debilitating for the patient, then CMC may not work in such situation. In such situation, you have to move on to some other formulation with some other properties. Level 3, there are visible signs. Not only the patient is symptomatic, but if you stain the cornea, there may be staining of cornea, there may be SPKs, the conjunctiva is stained, or eye is always inflamed. In this group of patient, only lubricant is not going to help you. You have to include an anti-inflammatory drugs. And that part I will come in my subsequent slides. Level 4 means there are structural damages like punctal stenosis is there, symblepharon formation is there, fornicial shortening. Most of the cases of cicatricial conjunctivitis will present with these findings, or there is filaments in cornea. When these findings are there, remember your lubricating and anti-inflammatory, they are not going to work. You have to include these two as well as some other intervention, maybe punctal plug, maybe neurotization, or maybe some other investigational drugs that has to be used. So this is overall how you answer choose the lubricating drop. And this is the TFOS due to criteria. If you see this stage 3, okay, there as well as stage 4, in stage 4 as well as some cases of stage 3, anti-inflammatory drug they recommend that should be given. But remember these are the signs, various signs when you should know that yes, the patient is getting a lot of surface inflammation. There will be conjunctival hyperemia. You can stain the conjunctiva. You can do this lip cock test. Confos can give you increased inflammatory cell like keratocytes, or T osmolarity. If you do it, it may come high, more than 300 milliosmol per liter. And nowadays some kits are even there for cytokine analysis. The cytokine levels may be raised. So these are all signs that would suggest surface inflammation is there, and clinically also you can guess that. So if you see inflammation is there, then you have to treat it. So the major challenge with us is we do have steroids. Steroid is a highly potent anti-inflammatory drug, but dry eye patients are chronic. You cannot continue steroid for lifelong. So the other option that available to us is either cyclosporine or nowadays tacrolimus. But remember, tacrolimus has not been investigated as a drug for dry eye. This we are using that, but that is never indicated from any study. But cyclosporine has been proven, especially initially cyclosporine 0.05 was FDA approved for management of dry eye cases. But the formulation that we have been using over years, 0.05, it has some limitations. One, burning, stinging. Almost all of us, whoever has prescribed cyclosporine, must have encountered this. Patients do get a lot of burning and stinging, and some patient may come with even sore throat because of that drainage of cyclosporine drugs through the NLD to the nose and then to the throat. The second, it takes at least 8 weeks. If you want to give cyclosporine, you have to club it with some sort of steroids like loteprenol or fluoromethanol, because steroid will give you immediate effect and cyclosporine will come into action after 8 weeks. So these are the two major problems associated with the older formulation of cyclosporine. And the reason is this: your cyclosporine is a water heading molecule. It's hydrophobic molecule. So aqueous solubility is poor. So the moment you put it in eye drop, the penetration is not that good. So to overcome that, a lot of company, they came out with new technology, and I think Sun Pharma came out with this technology of N-cell technology, cyclosporin 0.09%, and I think the product is Sequa, which is there on your chairs, I guess, almost all the chairs. So the advantage of this is the molecule was hydrophobic. Okay, so what they did, they covered it with a hydrophilic shell, so that it can easily pass through. If you see this image, so it can easily pass through the aqueous barrier and reach the epithelium. Once it reaches epithelium, then the active cyclosporin molecule, which is hydrophobic, is released. Then a lot of study was done before the approval. I'm not going into the details of this study. It would take 1 hour for me to go through all these studies. So safety, efficacy, everything was tested. But what I would suggest, what I would mention here is the main highlighted point of all these studies clubbed together. So okay, so these are the main points that one would interpret if you go through details of all this study. The most important for me as a practitioner is less irritation as well as burning sensation. The moment you put cyclosporin, a lot of patient, even almost 10 to 20% patient, they discontinue using this because of that local stinging pain. But that part is not there in more than 95% of the patients in whichever study was done with this 0.09% formulation. The second part, classically cyclosporin takes 6 to 8 weeks, but with this 0.09 formulation, the action started at 14 days. So steroid dependency, which is usually 4 to 6 weeks, that comes down to only 2 weeks. And in addition to all this study, at 3 months, what they came out that the tear production also improved at 3-month treatment. And at 1 year, there was even some improvement in best corrected visual acuity. So these are the summary of all the study that I simply skipped through. So these are the advantage of using a 0.09% NM cellular preparation, that nanomicellar preparation, that helps you. But before concluding, I would like to highlight one important thing. Remember, all these lubricating drops, whatever you're using, they are not treating the underlying disease. They are primarily symptomatic, and they are primarily treating the consequence of the primary disease. So always remember to rule out the primary cause of dry eye. In some cases, it may be idiopathic, only ocular surface inflammation is there. But as you can see in this image, it was a case of ocular cicatricial pemphigoid. Likewise, there may be SJS, there may be Sjogren, there may be some underlying connective tissue disorder like rheumatoid arthritis. So all the disease can have severe dry eye manifestation. So that part need to be taken care of. And second part, always remember, whenever you see a patient of 2 to 3 years on medications, please evaluate their psychological status, because nowadays from Western world, at least there are 30+ publications where they have confirmed that a dry eye patient may have symptoms like anxiety, depression because of chronic use of tear supplement and the persistent symptoms. And those patients who already have existent some sort of psychiatric problem, that may flared up because of dry eye. So please look into that also. At RP Center, even we are doing a research, and where almost all patients of more than 2-year dry eye on standard treatment, we are doing a psychological evaluation of them. And you won't believe, almost 30 to 40% patient, they are getting diagnosed with some sort of underlying illness. So that part you should always remember. And before concluding, I would like to invite you all. I am the current secretary, Delhi Ophthalmology Society. So our winter DOS conference is next week at Hotel Ashok on Saturday, Sunday. So if you people will join us, then we'll feel great about that. And second, DOS is doing a lot of online virtual programs. If residents are here, we are doing a postgraduate education program of 200 webinars. And for FECO learners, we are doing a virtual FECO development program. So that part you can come, and at winter DOS, we are doing some, you know, you have to take a break from study. So there are some take a break session also. This is the barcode you can scan to register, but I know most of you won't do that right now. With this, I'll conclude here. Thank you very much.
Thank you very much, Dr. Prafulla Maharana, for that exhaustive discussion on dry eye. He showed us, after all, that dry eye is not such a dry topic, and it deserves nothing less than felicitations from Professor Pandav. May I request Professor Pandav to kindly felicitate Professor Prafulla Maharana, please. we move on to the penultimate talk of this session, which happens to be from Dr. Ramlal Sharma. He will be talking to us about cool and calm surgery in phacodonesis, quick SICS. We are eagerly looking forward to this, sir, because the title is very enticing.
नमस्कार and धन्यवाद डॉक्टर अशोक शर्मा मुझे यहाँ बुलाने के लिए। ये बर्फीले ठंडे पहाड़ों का एक चित्र देख रहे हैं आप। शांति, शीतलता और शीघ्रता, that is what it means, calm and cool surgery in phacodonesis that can be quickly done. I have just a video presentation. There is just one video that will be run for a real-time surgery. This is how I do it. That is the direct tunnel keratome 3.2 is inserted at the limbus, creating almost 3.2 mm long and broad incision, and then subsequently extended with 5.2 millimeter extension knife and with 1 millimeter side cut. That almost makes the tunnel complete. As you can see, it just takes 40 to 50 seconds to complete this procedure. It's the way it is done in phacoemulsification, that you straightway go by just an keratome, push it forward, and almost 3.2 by 3.2 square incision is made. As you will see that this person has phacodonesis. Since the cataract is mature one, so dye is usually required in these cases just to carry out effective capsulorhexis. As soon as I'll push it, because I even do phacoemulsification with the same kind of posterior incision. Yes, can you see whole of the lens is moving? So I move slightly posterior and go by the superior can opening sort of capsulorhexis, as in the upper part the donesis is not that much. With the slowly and gently, as this is a real-time video, so it's unedited one. So as I can complete my rhexis despite having phacodonesis, but I'll always give 1 or 2 extension cut in upper part, so that there is no pressure on the zonule when it will be delivered, and try to release if there are any adhesion with the capsule, capsulocortical adhesion, which sometimes is seen that might push, that might put some pressure on the zonular while I rotate or do hydrodissection. Now you can see the same incision is extended, though it's slightly difficult as conjunctival flap is there, to 5.5 knife and 1 millimeter on either side will just make this tunnel appropriate. And as you can see, it has hardly, the surgery just 2 minutes old, and almost I am at the hydro dissection plus delineation, whatever is possible in these hard cataract cases, simultaneously with the hydro dissection, delineation, and sometimes even delivery I performed with the single step, as there are zonular weakness in this case, so I tend to remove this with the vectis instead of pulling it directly with the fluid only. So the minimal pressure will be there on the zonule, and you can see that this nucleus is delivered out. This was not too hard, but will be very, very safe in comparison to phacoemulsification, where the lot of pressure is put by the ingoing fluid while you do, and there is a likely chance that this tears through the capsule and ultimately may end up in the vitreous or the zonular dehiscence and the vitreous prolapse. The simple IA irrigation will just take out the lens matter. It is usually easier to remove this white cortical matter out of the eye in these cases. And as you can see, some pseudo exfoliation material is visible on the moderately dilated pupil, and rhexis edges are still visible despite having small cuts which I had given just to have an extra precaution that there is no chance of these zonule to go down. The extended section does not cause any leakage of the blood inside the eye. As you can see, the blood has never gone inside the eye. So it's almost perfectly sealed. Lens tend to spring back, particularly if it is a foldable IOL. That's why it needs to be anchored onto the side of this thing. And slowly you can push it into the bag, and ultimately lens is perfectly centered. Practically almost in 4.5 minutes, this surgery is nearly over. Remove out viscoelastic from up and below, whatever you can. Though I don't go very, very thorough in such cases, as lens is nearly well centered now. So this will finish almost surgery in next 5 to 10 seconds time. You can see that there's no leakage from the wound site, either inside or out. Neither blood is going in. I push some subconjunctival Genta Deca just to ensure that it is well sealed, and that finishes the surgery part. This is one of the simplest way in complicated cases to do this surgery. I had never encountered any problem of loss of anterior chamber, and I have never sutured except rare circumstances such wound. They are self-sealed. Post-operative astigmatism is not much, as the incision is quite behind. So the take-home message is that it is safe in complicated situation. All those who perform small incision cataract surgery, and it is easy, quick and good results, and it can be a rescue surgery in complicated cases where complicated phaco can directly be converted to SICS. Even under topical anesthesia, this surgery can be performed. Thank you very much.
Thank you very much, sir, for that wonderful video illustration of how to handle a tough situation, very skillfully done. I must say, not all of us can be as skilled as that. Thank you very much, sir, for that wonderful video. May I request Professor Jagatram to kindly felicitate. Can you please come up, sir? We go on to the last talk of this session, which will be by Dr. Sandeep Mahajan, an extremely prolific surgeon in Himachal, and he will be talking to us about another vexing situation, phacomorphic glaucoma with high hypermetropia, with a power of emmetropic IOL power of 27 diopters, multiple problems in one.
A very good afternoon. First of all, thanks to Dr. Ashok and Chandigarh Ophthalmological Society. And hats off to Dr. Ramlal. You don't put suture in such a big incision. What a guts you have, really. So, this is my patient. This is video based. Now, you know, today's era, even simple cataract is a challenge because expectations of the patients are very high. And post-cataract surgery, the patients are able to see better than the persons who have not undergone surgery, who are not having cataract because of the EDOFs and because of multiple multifocal lenses, toric lenses, because it is a refractive surgery. So I'll say simple cataract surgery is a challenging surgery in today's present times. I have got a cataract surgery. The life is now more than 42 years. Still, I will say that you come across a case which is really challenging case, which is I'm going to present to you. So this patient, 65 years old female, I operated this patient around 8 years back. with a power of 27 diopter IOL. And I will say, out of my experience, the female patients, especially hypermetropic, they are extremely happy post a successful cataract surgery because of the vision they get after surgery is much better than the vision they had prior to the surgery throughout life, because most of the females, they don't use glasses. And because of the magnification, they can even read without glasses. That I observed, high hypermetropy. So she was very happy patient. But for the second eye, she was neglecting it in spite of deterioration of vision. One day she landed in a general hospital with the headache, vomitics, and she was treated by general physician. And then later on, it happened to somebody that eye should be checked. And when eye was examined, she had an attack of phacomorphic glaucoma. And she came to us after 3-4 days. And we tried our best to put her on anti-glaucoma treatment. And with treatment, her IOP was only 40 millimeter of mercury. Now this was really challenging case for me. So how I proceeded? Axial length 20 millimeter of mercury. So this is a swollen lens. So the recording started a little late. I'm sorry for that. So you can see cornea is hazy. Pupil was this much dilated. So you have to go very slow, and your side port has to be deep into the cornea because there is a chance of iris prolapse. Iris is very, very floppy. Hardly there is any AC, maybe 1 to 2 millimeter. And now this incision, I will say you should take all the time in the world. It should be squarish incision because iris will have tendency to come out. And then I started doing waxes blindly, but nothing was visible. So I converted it into a can opener kind of thing, which I have observed that if you do can opener, it doesn't extend to the equator. Your posterior, now you can differentiate the two pictures. So cornea is getting little clear, and phaco with great difficulty, slowly it is very difficult to enter the anterior chamber. I was apprehensive, so getting out of the field. So I did phaco cleaning, phaco aspiration, no energy, just because these cataracts are hydrated cataracts. They are not very hard. So I'm trying my best. I do normally cartwheel cataract surgery, which I'm doing in all my cases. But I'm trying to do cartwheel. The nucleus is not moving much. With little phaco power, I'm able to eat some part of the nucleus. The visibility is very low. So I'm a single hand surgeon. If you put second instrument, chamber is going to collapse immediately. So somehow I'm able to move the nucleus, and I'm trying my best to do cartwheel. I have to save my endothelium and posterior capsule. Now I change my plan, so I extend the same incision. It's almost more than 4 mm, 5 mm. Then dial out this nucleus, which you can appreciate. It has got 2 halves, and put my wire vectors and take out the 1 half, because usually this is a soft cataract. The phacomorphic, usually it's a soft. And the second half, iris is not disturbed. You can see the floppiness of the iris, and then just cleaning of the cortical interior. chamber is deep now. So I will inject my IOL, leaving some of the cortical matter. Cornea is getting little more clear, and it goes into a sort of bag, one steel suture. I could leave it, but one suture I have applied to be on safe side. And then from the sideboard, I do dry aspiration. So whatever the cortex is left, with a syringe, 10 cc syringe. So I could complete the case. And patient had post-op vision of 612. Intraocular pressure was 16 millimeter of mercury. That was 1 month post-op. So that was the case which I wanted to present. Thank you so much.
Thank you so much, sir, for showing us another way to handle a really tough situation. May I request Professor Dr. Dami to kindly felicitate Dr. Mahajan, please. Before we adjourn for lunch, before the attention shifts to thought for food, we will have one last session of food for thought. And that will be a panel discussion. You have all been a good audience from the morning, but a quiet audience. So now is the time for you to really make a noise. So we would elicit questions from the audience. We would entertain any questions from the audience to our panelists. Professor Jagatram, some of the panelists have left, so we have with us Professor Jagatram, Professor Pandav, Professor Prafulla Maharana, Dr. G.S. Dami, Dr. Ranjit Daliwal, Dr. Faisal. May I please request all of you to please come to the front row, please. We had a set of pre-planned questions to our esteemed panel, but I would encourage anybody from the audience to please, can you please give the mic to the audience, please? Can you please give a mic to the audience? Anybody from the audience has any question of interest to you, which you wanted to ask but did not ask or could not ask up till now?
My question to Sir Dr. Jagatram.
Please.
Sir, is there any preference of IOL material or a type of IOL in case of uveitis, complicated cataract? Hydrophobic, hydrophilic or something?
Oh, definitely. I think it goes without saying at present we use all the hydrophobic acrylic IOL. Initially, in the beginning, we also had that time apparent surface modified IOL. They were PMM IOL mostly, but at present we use only hydrophobic acrylic IOL. We never use silicone IOL in these patients.
Else from the audience has a question? Sir, please go ahead.
A question to Professor Jagatram. It's about the choice of three-piece IOL in a patient with uveitic cataract. Why is that?
Yeah. Actually, once it is a hydrophobic acrylic IOL and it is a square edge IOL and it is placed in the capsular bag. In the beginning, I think initially we used to use more of the three-piece IOL, but at present we use more of the single-piece IOL. But studies have shown that it makes no much significant difference in the PCO rates, whether it is a three-piece IOL or single-piece IOL. which is as square as IOL, modern IOL, placed in the capsular bag.
We invite more questions. In fact, I am prompted to quote this. The only stupid question is the one that you wanted to ask but did not ask. So please go ahead and ask.
Type of training for such wet lab that you material you
Sir,
show us.
I am a one-man army. I have a small practice in ophthalmology. By all means, you can visit Bangalore. Whenever you happen to visit Bangalore, you can come over, sir.
I have a contact number from Dr. Ashok. So we'll try to come to you for short-term training, preparing these materials.
Or I can come down to Ashok Sharma's place for 2-3 days or a week. Anytime. I love Chandigarh.
Sir, you can come to Himachal anytime. So
Sure, sir. Thanks for the invite. Definitely we can work it out.
Sensitize our all youngsters.
Sure, sir. Thank you very much. I have a question myself. Please, in the meantime, please keep thinking of some questions. I have a question for both Dr. Pandav and Dr. Faisal. It's among the list of questions that we had planned. When exactly would you advocate a peripheral iridectomy? Obviously, an YAG laser peripheral iridectomy in patients with shallow AC and occludable angles. When exactly is it required? Because there are a lot of patients going around who come to us and then say so-and-so had suggested YAG PI, whereas we may feel that YAG PI was not required in that case, and vice versa also. We feel it's required, someone else tells the patient, no, no, that's not right.
I think you're talking in terms of angle closure.
Prophylactic.
Prophylactic or angle closure.
Suspect, basically.
Disease, basically, right? So I think the only indication is when you have like PAC stage, I would say, or PACS, which is perceived to be a high-risk patient. That's kind of primary glaucoma I'm talking about. And if it's a secondary glaucoma angle closure, and then anytime you get the iris Bombay kind of a configuration, so, or a pupillary block kind of a configuration is there. So that would mean that in primary angle closure disease, you have to have at least 360 degrees, some evidence that there's a, at least 180 degrees, some evidence that there's a occludable angles that we classify them as PACS. But you don't do idotomy for all PACS patients because the for conversion from PACS to PAC or PACG is actually quite low. So even if it progresses, you still have a space there to handle these patients. So they're not going to get kind of blind overnight, these patients.
So which of the PAC patients would you recommend?
PACS patients we will see which has at higher risk of visual loss basically. That would mean that the patient who wouldn't, who's a one-eyed patient, where the access to healthcare is not easy, and you have a patient who would need like a repeated dilated examination, because sometimes dilated examination can precipitate angle closure. Though, again, it's not a very common scenario, but sometimes does happen. So I think these are the few situations where you would do at a PACS stage.
Prophylactic.
Yeah,
Okay.
prophylactic.
Anybody ready with questions from the audience, please? If there are none, then I will myself ask two questions to both Dr. Jagatram and Dr. Dhami. Two issues which we always, significantly face. One is intraoperative meiosis in patients during cataract surgery, and the second is unexpected upthrust during cataract surgery, which is rather stubborn. So how to deal with these two situations? Professor Jagatram can take up the first one and Dr. Dhami the second one.
First, your first question is if it is a small pupil.
Which goes down, the pupil goes down intraoperatively. It was good to start with, but as you start phaco, it just goes down. So
definitely there are certain patients where people initially may be fine, but it goes down. Many of the patients of pseudo exfoliation, their pupil may go down, and some of the other patients it may go down, but you can inject intracameral mediatric, and I think you can, if it does not dilate, I think even after putting viscoelastic, then we are prepared to place iris hooks. Iris hooks is one, and ring, I think one of the, you can place ring whether it is any of the Indian or any of the port dilatation of people. Usually it will, you will be able to perform surgery.
Thank you very much, sir. Dr. Dhami has another point.
Jagataram has said excellent points, but I believe when you see the patient in OPD and put him on the list for cataract surgery, a definition of meiosis, intraoperative troubles will come to your mind. How the pupil dilated when you saw him first time. Now, once you have forgotten this and the patient has reached to the OT table, immediately you will see the thickness of the iris. You can define, grade and calculate the floppiness of the iris. That will give you an idea that the pupil is going to short up or intraoperatively constrict while you are operating. Now the stage comes when you are operating. You have crossed all this, you don't have hooks, everything. Please lower your parameters. Lowering parameters means bottle height goes down, vacuum in the AC goes down, you are on a slow motion phaco. Third thing, intraoperatively see that your both instruments, the chopper, the phaco probe, are in your viewing axis. You are not fiddling with your chopper going near the iris or your phaco tip going behind the iris. Please wait for the fragment to come to the phaco tip, rather you go to the fragment. That will create minimum turbulence in the anterior chamber. Don't come out. Coming out at this stage means you will create the floppy iris to go beyond your wound if it is not reconstructed in a right way. So that's, and finally when you can't do anything, don't hesitate to put hooks or rings, whatever you like. But we have done a study where preoperatively OCT done on a case for cut for phaco will define whether these people will shut up or short up during phacoemulsification.
Thank you, Dr. Dhami. Many of us may not know that Dr. Dhami has designed a special chopper which you can chop in a small pupil without damaging the iris. And I have used this chopper in various situations, and also because these days we don't have anything to dial the lens during cornea triple when there is open sky. So this chopper comes handy when we are doing cornea triple and we are dialing the lens. It's a beautiful instrument, and I think he gifted in the last conference, but I think everybody should keep it with him as great innovations.
Thank you, Ashok. That's Dr. Abhinav, my son's. Not an innovation, I say. Just when you're in a problem, you get an answer. Now you have got a pupil, you don't have hooks, you have nothing, you are in the chamber. In your tray should be this white chopper, Dhami's white chopper, which has a hook on one side and a chopping instrument on the other side. It keeps the iris away and you can keep pulling the nucleus. Thank you.
I have another question to both of you. Many of sorry, Professor Jagataram has to say something.
Last session, last year, in that session that chopper and hook was shown, and it was excellent video. It is, I think, good for if it is a moderately dilated pupil, and you can hook the pupil and take the chop the nucleus, and like this you can rotate and do it in the lower part. So that is what I remember, and I think it is an excellent one.
You have described it very nicely. Still worse is when you are doing toric IOLs.
Yeah.
Your pupil is bound to constrict and
right.
the toric markers are out. Then you can use it. Like Dr. Ashok said, he uses it during cranoplasty. It's wonderful. Thank you, Ashok.
I have one more question to you both. Sometimes when we want to operate a patient for phacoemulsification, those who are on Urinex, one of my patients went to urologist, and the urologist said you stop it and then it will be fine. I don't think, but what is your...
So, whether you have taken it for 1 day or 1 week, 1 year, the action of that temoxicillin is same. When you stop it, it doesn't give you any help. The only help I told you is preoperative OCT of the RS, that will thickness. If the thickness of the RS varies in various segments of the OCT, it will give you an idea that you're going to have a troublesome RS during that. Then the next step is please check your sideboard. It should be just nugging the chopper. Means you have calibrated blade or a calibrated chopper. Your incision should be what you want and not what you create. Means exactly 2.8 or 2.2, whatever you are used to. Not fiddle with here and there. And third is, you must have heard about a small incision being done with incision being enlarged here and there. That is called a reverse from incision for removing the nucleus. Here your phaco tip will not move on the RS, it will move cross like a bow, rowing boat. Your phaco handpiece is going to move like this. So your incision matters the maximum, especially the sideboard.
Yeah, using a meringotomy knife, which we used to use in those days of 20-gauge surgery, which has a diamond shape, will really create an opening which is not redundant and the side port instrument snugly fits there, rather than using our regular side port knife.
You are only 26 gauge, 27
gauge.
Do that.
May I now ask Professor Praful Maharana, which are the other situations in our daily practice where cyclosporin finds a use?
Thank you for that question. So nowadays, cyclosporin we are using in cases of VKC, because VKC patient, a lot of patient you will see they become steroid respondent and they develop glaucoma and don't have a choice. And in those cases, we use higher strength cyclosporin, 0.1% or maybe more than that. That is one. Second, people are exploring this in cases of adenoviral keratoconjunctivitis also, because adenoviral keratoconjunctivitis can lead to your SPKs, those immune infiltrate. So earlier people used to use steroid universally, but nowadays one school of thought is if you give steroid, then it prolongs the process. The moment you stop the steroid, it recurs, again you start steroid. So people are using cyclosporin for that instead of steroid. So those are the two very commonly indication. And at RP center we are exploring cyclosporin role in fungal keratitis. Because fungal keratitis, we all know steroid is not indicated, contraindicated, but inflammation is definitely there. That is more damaging to the surface. So we are doing a study where we are giving cyclosporin to patients of fungal keratitis, just to check what is the response, healing, edema, vascularization at the end of the healing.
Dr. Praful Maharana, what advantages do you find with 0.9% versus previous preparations of cyclosporin?
Practically, actually, this is the same question somebody asked me when I was coming from station to here. The difference, patient may not feel that much, but as a treating physician, you can easily appreciate those findings. Because if you are telling a patient of suppose SPKs, if you give cyclosporin 0.09%, the response comes quite early. And the rate of complaint, if you give only cyclosporin without this formulation, so the complaint rate of stinging, all these things are quite high. And rate of discontinuation is also high. But with this new formulation, that is not that significant.
Thank you so much. Dr. R.S. Dhaliwal, manual small incision cataract surgery is an excellent procedure, and Professor Ramlal showed the video, and you are pioneer of this surgery. What tips would you give to the beginners who would like to venture this procedure? Because most of us have not been trained in this area. And I think Dr. Pandav and Dr. Praful will agree that in institutes, I don't think we are training people to perform this surgery.
Thank you for the question, sir. But interestingly, nobody's been trained, even I was not trained for this. I have been creating havoc with my initial patients, and I would just request everybody to stick on, not to worry about the CP or anything of that sort. Continue with the surgery. These days, we have a lot of videos on the YouTube. They're good enough. There's so many centers who have their YouTube channels. You just follow those videos, and I think it will be wonderful. I give you a few tips here, just for academic interest, I would say. But watch videos. That's what I was told, and interestingly, I had only one video. So I would keep seeing it again and again, create havoc, again go back to the same video. That's it. Thank you.
So just to add on to that, in fact, that is what me and Padam sir were discussing. If we train our resident in SICS, although no, but if you go by the Government of India data, 80% of cases done in India are extracapsular. So don't carry this concept that if you know phaco, that is good enough. You have to learn SICS, and before becoming faculty, I went to LB Prasad as a cornea faculty, and my first case was SICS because it was a non-paying patient. So in private practice, the patient is not paying, they won't use phaco machine. So I had to do an SICS in my first case. So SICS is as essential as phacoemulsification that everyone should master.
Thank you very much, sir, for that straightforward and forthright answer and sage advice. Professor.
I agree to Dr. Tariwal that we were never taught anything. But my message is, every step, the one from cutting the conjunctiva to making the incision to the rexis, is first one is complementary to the other. If you have not done a good exposure, you can't get a good incision. If you don't make a good incision, you can't remove the nucleus. If you have not done a good rexis, you will not do this. So what we do is, we do SAS when we are in complications. We are lost. And then we expect it to be the same as it was presented here. So remember that your situation when you are doing SSCS is different. I wish if you want to learn, please plan to do SSCS. That means you will be planning your incision, you will be planning your nucleus. I have never done it, but I should know it because in phacoemulsification you need it so many times. It's must for everyone, but not in a stage where you have already created a complication. It should be in a stage where there is a primary planned surgery.
Yeah, to put it simply, you must graduate to phacoemulsification from SICS. That would be the right approach. Rather, and it's not so. Is there one last question from the audience? Yeah, Neeraj has one last question. After that, we'll have a talk by Dr. Harpreet Kapoor, please.
Learned speakers about dry eyes. I have a particular problem, I'm sure everybody has. Sometimes we do get patients of very severe filamentary keratitis, for which we generally don't have any answer and patient keeps on suffering. So I want to invite suggestions that if you have something particular which is recent and which works for filamentary keratitis. And in addition, if possible, I like to know the role of scleral contact lenses in severe dry eyes.
Thank you, sir, for that questions. See, filamentary keratitis, while treating it, we find acetylcysteine 10% is quite useful. And one company has come up with a formulation also, 5%. But I don't know if it is available in India yet. So 10% acetylcysteine definitely will help you. And remember, use high potency steroids. Don't go by this lotipril furomethyl. That is not going to work in filamentary keratitis. Third point, if the fila points are severe, then you have to manually remove it because no drug will be able to take it off. That is another. That is one aspect. Second, as I highlighted, underlying cause, because most of the time the filamentary keratitis patient that we see, they do have some underlying connective tissue disorders like rheumatoid arthritis. So you have to identify that cause and treat it. And there are some studies, and even I found quite useful, you can use hypersol ointment, hypertonic saline, because these filaments, they do have edematous epithelium as well as mucin. So that may help you in some of your cases. Regarding use of scleral contact lens, remember scleral contact lens is not going to treat the filaments. It is going to protect the filaments or corneal epithelium from getting mechanical protection from the lid movements. So scleral lens is useful in severe dry eye patient because it takes care of the windpiper epitheliopathy or the continuous movement of the lid that damages the epithelium. It won't help in filamentary keratitis treatment, because filament will still be there if you use scleral contact lens, but your patient will definitely get symptomatic relief. So you can use scleral contact lens, but you have to treat the underlying cause for those filaments.
Thank you very much, Professor Prafulla Rana. I now request Dr. Harpreet Kapoor, who is Asian advisor to the German-based NGO Christopher Blinden Mission, to kindly enlighten us very briefly.
Excuse me, sir. Can I ask one more question? Okay, sir.
Go ahead, sir. I have been given the license that you go ahead.
Thank you, sir. Thank you so much. A lot of, as we all know, a lot of diabetic patients are coming now, and I want to know from the experts that sometimes they force for multifocals and trifocals. So is diabetes a absolute contraindication for multifocal and trifocal lenses, or it's a relative contraindication? Like I have implanted a multifocal in a patient 6 years back, and he came to me, my OPD 2 days back, same patient, and I have to put a multifocal in the other eye because now patient has developed diabetes, and that time 6 years back he was not having diabetes. So any expert comments, sir?
I think in a patient of diabetes where there is a diabetic retinopathy, even NPDR or beginning of the diabetic retinopathy, one should not implant multifocal IOL in these patients. And once in a patient where there is a NPDR or even early diabetic retinopathy or advanced, no question of placing multifocal IOL in the and where there is no where control is excellent, but there is absolutely no diabetic retinopathy, selectively one can put multifocal IOL, but by and large majority of the patients we do not put multifocal IOL.
I agree with Dr. Jagadram sir. I would like to ask the patient, why does he need a trifocal? He will answer himself whether he wants a trifocal or not, or a multifocal.
Dr. Harpreet Kapoor, please, can you please enlighten us very briefly about Vision 2020 mission?
Yeah, am I audible?
आप इधर ही आ सकते हैं. आइए मैम, you can speak from the lectern.
I must confess, I was shocked rather when you said a talk, because it was not planned.
Right, I am sorry about that.
No, that's okay.
Even if you give us a talk, it's fine.
I can do it, can talk about Vision 2020 extempore also, so I can say a few words if you want me to.
Please go ahead.
Okay. Thank you so much, and in fact I'm glad that you have actually, you inadvertently probably shifted to this much neglected area, and I understand everybody here is interested in learning the most advanced techniques and even multifocal, trifocal. We were ready to skip lunch but talk about trifocal lenses. And so, but I will, just try to take you to an area which is largely neglected. So we do try our best to kind of, address problems of patients who are coming to us for trifocal lenses. We, do a perfect surgery, they are still not happy. But then we often forget that there is a large segment of the population which, does not have access to even basic eye care, and they cannot continue with their daily lives. In fact, even their bread and butter also, if I may say so. Having said that, if you talk specifically about Vision 2020, well, Vision 2020 is an initiative which was launched way back in, I would say, 1999. And this was a collaborative effort of WHO and IAPB. And the main aim was to address avoidable blindness. And actually they wanted to, it was a plan to eliminate avoidable blindness by year 2020. So, and then this was of course a global movement, and India chapter also began, and by the efforts of, I think it was mainly L.V. Prasad, Arvind, and then NGOs like CBM. I am actually very actively working with an NGO, CBM. It is an international NGO based in Germany. I'm the advisor for Asia, so I think that's why Dr. Ashok kind of, told me to just share the kind of work we do. And so, like I said, Vision 2020, it was till year 2020, much has been achieved. The aim was to address avoidable blindness, the main causes being cataract, uncorrected refractive errors, trachoma. And I'm glad to share, I don't know how many of you are aware, but in October, WHO has sent out a dossier saying that India is now free of trachoma, and it's all thanks to all the ophthalmologists across the country and the government of India also. So that has been eliminated from India at least. And but yeah, like so after Vision 2020, I would say now that the forum is continuing, and now we are talking about 2030 inside. So a strategic plan is in place now by the IAPB, and the main aim is again now to address the newer challenges. We know we have been addressing communicable diseases, but now with the lifestyle change, aging population, diabetic retinopathy, glaucoma, age-related macular degeneration, all these are the newer causes of blindness. And to address these, the strategic plan has come in place, which is the 2030 Insight initiative by IAPB. And it mainly talks about, it talks about activating, elevating, and integrating eye health within the larger government health sector, so that we can kind of reach the most marginalized population and address their needs. It's not just about addressing cataract and the avoidable causes now, it's also about giving a good quality of life to people who have irreversible blindness. So that we have, we set up low vision services, rehab services, so that they can also achieve their full potential. And this is in line with the SDGs, the Sustainable Developmental Goals globally.
Thank you, madam. Thank you so much.
Thank you. So I think I've said enough, and
thank you so much, madam. Sorry for the unscripted.
No, that's perfectly fine. I could stand here and talk more also,
Thank
but
you so
yeah,
much.
I am aware everybody is waiting for lunch. Thank you so much for the opportunity.
Thank you so much, madam.
To share.
Some more exercise for Dr. Pandav and Dr. Professor Jagatram and Professor Pandav. We have the pleasant duty of announcing the winners of the competitive section in the morning. The winner happens to be Dr. Ashok Kumar, whose topic about blood-associated endophthalmitis with Neisseria mucosa gets the best prize. The winner, he is the winner of. Dr. Faisal will collect the award on his behalf. May I request him to please do so. Congratulations to the winners. A very close second, a runner-up is my very dear friend, Dr. Rajan Sharma, for that excellent paper on stem cells, etc. We have been very successful in almost finishing on time. That speaks volumes about how the speaker stuck to their time, and also the audience didn't prolong the questions. So, may I request all of you to please, after this, to please come up on dais for a group photograph before we go for lunch. We are delaying your lunch by another 2 minutes. May we request all of you to please partake in lunch, but please assemble back by 2:15.
A metallic foreign body. It is a tricky one, or we will wide open the track and pull it.
May I have your attention, please? May I have your attention, please? There is a car with the bearing the registration number PB11B 27123, which is obstructing traffic, which is obstructing movement of other vehicles. If it belongs to anyone from the hall, can you please move it out of the way? Sir, I repeat, the number is ending with 7193, PB11BZ 7123.
Good afternoon, everybody. We are going to start the post-lunch session, and very interesting session. This is Chandigarh Eye Film Festival, 2 minutes to win. So I will request all the judges to please come to the front row. Professor Anil Verma, Professor Anil Verma, Dr. Amanpreet Kaur, Dr. G.S. Mangat, Dr. Neeraj Sood, Dr. Faisal. Dr. Faisal, please. Dr. Rakesh Gupta, Dr. Vasbraj, Dr. Vikrant Sharma, Dr. Rakesh Gupta, Dr. Gurstinder,
वाला पेपर्स
evaluation sheets का Mr. Agnivesh to provide the evaluation sheets please. Mr. Agnivesh.
सेम क्राइटेरिया नहीं सेम इसमें अलग क्राइटेरिया सेम
evaluation sheets पे लिखे टाइम का
नहीं नहीं सेम जो सुबह था वही है ओरिजिनलिटी कंटेंट
वैसा वैसा ही वैसा वैसा
आपका नहीं है बोल रहा है ना आप
क्या चीज़
आपका कॉम्पिटिटिव नहीं है करके बोल
मेरा नहीं एक कॉम्पिटिटिव नहीं दो और हैं मेरे ना फर्स्ट वाला नहीं है कॉम्पिटिटिव ये बोल रहे हैं ये बोल रहे हैं कि दिस वाज प्रेजेंटेड लास्ट ईयर एंड इट गॉट AIUS अवार्ड एंड दिस इज जस्ट वी आर जस्ट जिसको आप बोलते हैं स्टार्टर तो नंबर 2 से है एंड लास्ट वन अगेन इज नॉट कॉम्पिटिटिव
अच्छा
जो डॉक्टर धारीवाल
I hope all the judges have got the evaluation sheets.
सर कभी
Dr. Dami doesn't want to be a judge. Thank you, sir. We have a total of 14 videos, which are all 2-minute videos. The first one happens to be presented by Dr. Ashok Sharma, which won an award in the All India Ophthalmic Conference last time. He just received it from Dr. G.N. Rao in the midterm conference, and this is also published, I think, in IJO. Fishing out deep stromal foreign bodies. Judges, to please note that this is not to be marked. We are just starting off with his video just for our consumption. Dr. Ashok Sharma, please. It will be, all of these videos will be, they are preloaded and they will be coming on their own, I think.
Hi Sharma, let us go for fishing out deep corneal foreign bodies. Wow, you know fishing. I doubt it. I shall teach you fishing as both need patience and perseverance. Let us take up the first case. You can see the foreign body. We will open and widen the trap. It is not possible to hold and remove, we will scoop it out. Here it comes out wonderful. So, the first lesson, put a barrier and do not let your catch go into the deep waters. Let us go to the second case. Oh, so many fishes, foreign bodies. These are full thickness vertical wooden and need to be removed in total. So, to catch many fishes at one time you need different strategy. I shall go deep, enter the anterior chamber, push these from behind and pick up one by one. Let us start the third one. Oh, Sharma, you have become an expert. Yes. I have a silvery fish, a metallic foreign body. It is a tricky one, or we will wide open the trap and pull it. Not successful. Does not matter. Let us go inside like the previous case. Here I do not find. So I found it is there deep in the anterior chamber. Let us increase the entry and use retina faucets to remove. Wow, wonderful. So, now you understand both fishing and fishing out deep corneal foreign bodies need patience and perseverance.
Thank you very much.
Thanks so much, Dr. Ashok Sharma. Dr. Pawan Puneet will be talking to us about sutureless scleral fixated PCIOLs deferred, ingenious and sutured ways still an option.
Humbled sharing. Thankful reference for our technique turned retinopathy to a lens OT. But as well said, one size does not fit all. We hereby share the fit case scenarios where we sought an alternate option as IOL tilts develop negatively like in this case. First, IOL orientation assessed, tilts managed using 9-0 proline as a parallel scaffold suture passed under self-series graded pockets and IOL titrated to bring the parallel to the iris peg, resulting in a well-centered IOL and in some cases rectifying high cylinder up to 30 diopter. Another scenario of one-eyed patient with subluxation. So after clearing the victors, we de-engaged the haptic of the bag, brought out and retained there with the aid of silicone band segment on either side. Remnants of the capsule bag cleared, haptic stuck bearing only as in our SFL tip, resulting in well-centered IOL. Sharing an interesting case of dancing or floating optic in anterior chamber, where haptics of the 3-piece IOL got separated and sturdily fixed within the fibrous backbone was challenging. Using 2 microforceps, we could thread back haptics into the optic edge, resulting in well-centered IOL. Zonule dialysis with PC ring, posterior capsule opening refreshing for optic capture button hole by 3-piece IOL. Another case with CPR in place and the PC ring also managed similarly. Subluxated single-piece foldable IOLs can be refixated to sclera by passing 9-0 protein suture through the substance of IOL at optic haptic junction on either side, followed by centration of IOL. Especially useful for subluxated multifocal indoors IOLs as fixated back, in this case to 62 degree. Thank you so much.
Thank you so much, Dr. Can we move on to the next one, please, by Dr. Pawan Prashar, contact lens associated phacoemulsification in post-hydrops keratoconus eye.
We present the case of a 55-year-old female with bilateral mature cataracts, status post-hydrop scarring in the corneas. Phacoemulsification was started as per routine incisions, capsular staining, and continuous curvilinear capsular excess formation. A difficulty was noted in raising capsular flap with utrata forceps due to dense anterior subcapsular plaque, so a cystitome was used to make an opening in the anterior capsule. Subsequently, continuous curvilinear capsular excess was completed with difficulty as the flap tended to run out. Hydrodissection was attempted, and at this time, gross distortion of the cannula was noted in the anterior chamber. It was very difficult to find the right plane to proceed with phacoemulsification. So, a large diameter rigid gas permeable contact lens was placed on the cornea to improve the view. These lenses work by minimizing the optical aberrations, thus reducing the distortions and improving visualization and stereopsis. Subsequent steps of phacoemulsification were carried out as routine by chopping of nucleus and emulsification of the fragments. Cortical aspiration was uneventful. At this time, the rigid gas permeable lens was removed and a foldable IOL was implanted in the capsular bag. To summarize, rigid gas permeable contact lenses can be very useful in such difficult situations with irregular corneas. Thank you.
Thank you very much, Dr. Pawan Prashar. Next will be by Dr. Rajan Sharma. Are you presenting? Taylor Bird suturing technique in eyes with positive pressure during PK. But judges, please note this needs to be marked. Only the first one by...
The author presents Taylor Bird suturing technique in extreme positive pressure during penetrating keratoplasty
The tailor bird uses the principle of stitching the least resistance area first. Conventionally, after passing 4 cardinal sutures, 1 suture in the center of each quadrant is passed. In eyes with high intraoperative pressure and iris prolapse, passing suture in the center is extremely difficult. Taking cue from the tailor bird, a suture close to cardinal suture is passed first, rather than in the center. Tailor bird suture technique is based on compression zone effect of corneal suture. Post definition 7.5 mm was performed. Three cardinal sutures were passed. Fourth cardinal suture was passed. From 9 o'clock to 12 o'clock, iris was prolapsed. Several attempts made to reposit iris with visco were unsuccessful. Taking cue from the tailor bird, suture close to the cardinal suture was passed. Another suture adjacent this suture was passed and the positive pressure and the iris prolapse subsided. Corneal suturing was possible as the compression zone effect of the sutures overlapped. On the other hand, if one has to struggle, in case central suture is passed first, as per convention, in case with high intraoperative pressure, additional sutures were passed to complete the suturing.
I think Dr. Dhami said rightly, necessity is the mother of invention. Before this technique, I have spent in one of the child 28 minutes to pass 2 sutures in penetrating keratoplasty in the GA. Thank you.
Dr. Ashok Sharma seems to be taking a lot of inspiration from nature. First it was fishes, this time it was a tailor bird. We go on to Dr. Ranjit S. Daliwal, who will be showing his video on visco expression of nucleus in manual SICS.
We shall be presenting here visco expression of the nucleus in manual SICS. In this video we are dealing with We shall be presenting here visco expression of the nucleus in manual SICS. In this video we are dealing.
I can present this later. I'll present the other one first.
Okay, no problem. We can go to the next one.
The next one is manual SICS in phacomorphic glaucoma, the envelope technique.
Greetings. Today we are.
I'll play these from my laptop.
Yeah, sure. We'll do in the end.
So since there's a small technical glitch, we will move on to the other presentation, next one by Dr. Gaurav Sharma, which is on ocular squamous surface neoplasia surgical technique. Thank you very much, Dr. Gaurav Sharma, for an excellent video. We move on to the next one. Dr. Geetanjali Sood will be presenting her video on subluxated cataract, transscleral suturing of haptic bag and CTR. Is she here? वो बाद में करेंगे डॉक्टर साहब हैं ना डॉक्टर महाजन उन्हीं के है ना तो फिर प्रेजेंट करने के लिए नहीं स्टार्ट वीडियो स्टार्ट कर You can start the video, please.
Cataracts are managed using CTR or CTS. We describe a new approach where we make a scleral groove adjacent to area of subluxation and then pass a 10-0 proline suture passing above and below the haptic CTR back complex and fixate it to the sclera. First case is a 36-year-old female with history of trauma and the area of subluxation extending from 9 to 1 o'clock. Capsular excise is done and then iris hooks are used to stabilize the excess edge at area of subluxation. Phacoemulsification is done and followed by insertion of the capsular tension ring. Then we aspirate the cortex slowly, followed by insertion of 3-piece IOL with the haptic stretching the bag at the area of zonular loss. This is followed by making of scleral groove and 10-0 proline suture is passed above and below the haptic back CTR complex by threading into 26 gauge bent needle, and finally suture is tied into the scleral groove. IOL is dialed into its position and is well centered. Next case has a 7 clock hours of zonular loss from 12 to 7 o'clock. Capsular excise is done using forceps and iris hooks are used to stretch the capsular bag. Followed by phacoemulsification, placement of CTR, aspiration of the cortex and then the IOL. Then we fixate the haptic bag CTR complex adjacent to area of zonular loss to the sclera using 10-0 proline suture. Conclude, we can manage subluxated cataracts with zonular loss from 3 to 7 clock hours using this technique.
Thank you. That was a video from Mahajan's Eye Hospital. We have Dr. Ashok Sharma again. He has conquered several indomitable peaks, but this time he is going to show us how to conquer the indomitable peak in keratoconus.
Present a hybrid technique for a patient with extreme ectasia 5 years after PKP for advanced keratoconus.
Hi, doctor. Conquering indomitable peak with an earlier aborted attempt is challenging.
Yes, but we can try the cargill war approach.
Okay, how will that help us to succeed?
We will first use intense artillery shelling from the ground.
Partial trephination with 10 millimeters trephine done. Lamellar dissection was initiated with a crescentic knife. Post-lamellar dissection carried on with DALK scissors. Lamellar dissection completed up to the previous host graft junction with a crescent knife.
What next? It is not over.
We need help from Air Force to conquer Cargill Peak.
AC entered and incision enlarged. The previous opaque penetrating graft was excised with corneal scissors. Full thickness donor corneal button 10.50 millimeters diameter, sutured with interrupted 10-0 monofilament nylon sutures. Our hybrid technique restored integrity and vision, and conquered the indomitable keratoconus, peaks similar to the cargo war.
Thank you.
Very much, Dr. Ashok Sharma. Dr. Jitendra Rootki will be presenting the next video, which is on trabeculectomy and manual small incision cataract surgery through an M incision.
This is a combined surgery, manual small incision cataract surgery combined with trabeculectomy in a single incision. This surgery is done by M-type incision or W or straight line incisions. Trabeculectomy is a standard procedure for glaucoma surgery. I have done more than 60 plus cases of trabeculectomy and manual small incision combined, and results are very good. IOP control is very good. In India, almost every surgeon does manual small incision cataract surgery. Tunnel making is easy and with the crescent knife. With a single incision bow surgery can be done, cautery of the small area and less scarring, duration of mobility is less, cost is very less. Manual small incision cataract surgery is an artistic surgery. You can change the character of the incision to reduce the astigmatism and also change the incision to accommodate the trabeculectomy. After incision, the cataract surgery is done by manual small incision cataract surgery. After implanting the IOL in the bag, window is made under the V flap and iridectomy is also done. Scleral flaps are secured with 10-0 nylon, and also the conjunctival flap is also secured with the 10-0. Air bubble is put in the anterior chamber at the end of the surgery.
Thank you very much, sir, for a very innovative M-shaped incision. Since Dr. Ranjit Daliwal will be presenting all his 3 videos towards the end because there's some issue with the format there, we request Dr. Nishat Bansal to present a notorious case of optic disc maculopathy.
A 26-year-old female presented with gradual blurring of vision after undergoing pars plana vitrectomy elsewhere for her optic disc maculopathy in the left eye. This photo shows a large area of serous detachment at the posterior pole with the presence of optic disc pit temporally at the disc. Her previous OCT shows large detachment which resolved after the surgery, but the fluid started to appear again at the posterior pole down the line. 3 months post-surgery, the patient presented with decreased vision of 6/36 with a sciatic retina and a large amount of subretinal fluid present under the fovea. The patient was taken up for resurgery in her left eye. After doing a localized conjunctival peritomy, a partial thickness scleral flap was created in the inferior temporal quadrant. LM was stained with the BBG dye to confirm the area of previous staining and ILM removal. All piece of sclera was harvested.
42.
Sclera was carefully stuffed inside the pit. Care was taken not to damage the cilioretinal artery which was present in this patient. This was finished with a careful fluid air exchange not to dislodge the graft. 5 months post-surgery, the vision had improved to 6/24 with the attached fovea. Autologous sclera is a cost-effective alternative for recurrent cases of optic disc maculopathy. Other options available are human amniotic membrane, fibrin blue, autologous serum. All these come at a cost. Sclera stays in a pit for a long term with good anatomical outcome as seen in our patient. Thank you.
Thank you very much, Optic disc maculopathies are always recalcitrant problems. Thanks for showing a nice case. Can we now have Dr. Nimrat Bajaj Dhami to present her video on bilateral acute iris transillumination?
Bilateral acute iris transillumination after PRK surgery. So this was a 25-year-old male who came to opine about refractive surgery. The patient had compound myopic astigmatism. His anterior and posterior segment examination and intraocular pressure unremarkable and corresponded with clinical evaluation. We followed the routine procedure in PRK, followed by moxifloxacin soaked BCL, pre-soaked 20 minutes in preservative-free moxifloxacin placed at the end of surgery with routine post-operative medications of lubricants. Up until day 14, this was a routine case. However, on day 15, the patient presented with pain and congestion in the left eye, so we just stepped up the steroids. Came back the next day with increased inflammation, IOP in left eye, so we added topical timolol eye drops and tablet acetazolamide. We realized that we are in dire straits when both eyes kept worsening and the patient kept coming back with increasing inflammation, IOP. Ordered systemic workup to see if there was any missing piece of this juggle. We added tablet valcyclovir in further days to come. Did every anti-glaucoma medication in the book. What distinguished this case was the dense pigment deposition on the anterior lens capsule, no keratic precipitates, only pigment cells in the interior chamber. A remarkable pattern of diffuse transillumination defects was seen on retroillumination. Working diagnosis of bilateral acute iris transillumination, strongly linked to systemic moxifloxacin in the past, which led us to ponder over our choice of pre-soaking our bandaged contact lens in moxifloxacin or prescribing it post-operatively. Other differentials were bilateral acute depigmentation of iris, buddy, pigment dispersion syndrome, pseudoexfoliation syndrome, viral iridocyclitis, but none of them entirely fit the picture. Treatment was titrated as follows: withdrawal of all moxifloxacin entirely, slow tapering of steroids, continuation of antivirals, intravenous mannitol to tide over the acute crisis, which soon settled. The waxing waning course over the next 5 months, pigment slowly disappeared from both eyes, ending this nightmare.
Thank you very much, madam, for drawing our attention to a rare but an important problem. May I call Dr. Sandeep Mahajan to please present what we are eagerly looking forward to in challenging situations of white cataracts. Rhexis is always a problem. He is going to show us a new method of vacuum rhexis.
Technique for white cataracts. Our first case is an intumescent cataract. After initial procedures, we give a central nick in capsule with cystitome and aspirate the cortex using pen 23 gauge cannula. The same cannula is used for holding capsular flap using vacuum built manually by pulling the plunger of 10 cc syringe. Then the flap is rotated circumferentially. The flap is periodically re-grasped at its hinge to have a good control. Here we note a usual point of rhexis extension with egress of liquid cortex. But as flap was under our control, we could rapidly redirect it and go on to complete our rhexis. Rhexis can also be enlarged using orange peel maneuver. Next case is a hypermature white cataract. These cases are more tricky as they have overall high intralenticular pressure. But with vacuum rhexis, we can have a good control over our rhexis throughout the case. Vacuum rhexis, we get a perfect circumferential curvilinear capsular rhexis in white cataracts without the use of any adjuncts.
Wonderful, sir. I am sure many will go back and start attempting it, if not today, at least from tomorrow itself. Thank you very much. Dr. Ranjit Daliwal, sir, will now be presenting 3 videos back to back. The first 2 are supposed to be marked. The last one is not for marking, please. Judges, please note. The first and the second videos that he is going to present are for marking, the last one is not.
Yes. In this video we are dealing with a rock-hard black cataract and a ready-to-construct, I'll be present. We should I'll be presenting here visco expression of the nucleus in manual SICS. In this video we are dealing with a rock-hard black cataract and a ready-to-construct pupil. Both these conditions are a nightmare for any cataract surgeon, particularly phaco surgeons other than the masters. Such cataracts are always accompanied by lax zonule. The corneoscleral tunnel is made with a crescent blade and a side port is made with a 15-degree knife. Closed chamber, circular curvilinear capsular axis is performed in keeping in mind the size of the nucleus. The radial nicks are given all around the rhexis margin. The anterior chamber is entered with a 2.8 mm keratome. The nucleus tumbling technique in real time. A gentle hydrodissection is performed with 26-gauge cannula. The nucleus is tapped on the opposite side to release the trapped fluid, and the cannula flips the nucleus out into the anterior chamber, partially. At this stage we shift to visco cannula. Visco does not let the anterior chamber collapse and has a cushioning effect on the PC as the nucleus is prolapsed out of the bag. Nucleus is delivered by visco expression. This reduces the repeated entry of instruments into the chamber and does not allow the anterior chamber to collapse at any step. Thanks for watching. Regards from my infirmary, Nabha.
Greetings. Today we are presenting a case of phacomorphic glaucoma being taken up for manual SICS. The surgery started with routine conjunctival peritomy, cautery, and partial thickness straight scleral incision augmented with radial cuts. Sclerocarneal tunnel is fashioned in the usual manner. After the sclerocarneal tunnel, we make a side port, stain the capsule and form the anterior chamber with viscoelastic. In this case, we did not attempt the rhexis at all. Rather we directly proceeded to the main entry. With the same keratome we punctured the capsule and debulked the cortex. Following this, the rhexis is completed with Vannas scissors and rhexis forceps with envelope technique. Hydrodissection is very gently performed and the pole of nucleus is prolapsed followed by cartwheeling and finally visco expression is done. The technique is very safe and endothelium friendly. Note that there was no loss of the anterior chamber at any point. Iris was not touched or teased. Injury to the iris in such cases leads to increased inflammation the next post-op day. There is no stress on already weak zonule. Irrigation aspiration is performed with lower bottle height. Most of the cortex is irrigated and expressed. A rigid 6 mm IOL is implanted in the bag. We prefer a rigid IOL in such cases as its haptics give a very good stability and centration in weak bags. Even months after the surgery, the centration of the lenses remains good. The optical quality and surface of the lens remains good even if fibrinous reaction is present in initial post-operative period. Visco wash is thoroughly done. Thanks for patiently watching the video.
Good afternoon, everybody. The third video is a documentary on cornea donation, and this was made by Vikram, and the background score is also by him.
Thank you.
Very touching and moving last. We really admire your spirit and what shall I say, we commiserate with you. I'm so sorry about that. As Dr. Sonam is going to get ready, may I request Dr. Dhami sir to please felicitate Dr. Ranjit Daliwal, please.
Well, there is a lot to write, innumerable words to say about Kumar Dhariwal. A son gifted, a son born with ophthalmology in his blood, a boy who left what Dr. Dhariwal is going to is showing everywhere, and what we all see, the concepts of small incision surgery, the incisions, what you wanted to learn today, he learnt, gave, and wrote years back. He left us so early. Probably good people stay very little in this world. They're needed by the other world, the God. I really congratulate and appreciate Dr. Dhariwal to be a proud father, and his mother is there. I am honored to be schoolmate, college mate, postgraduate mate of Dr. Dhariwal, and proud to give him this souvenir.
Dr. Sonam, please.
Thank you, sir. A very good afternoon, everyone. This video is just a small experience in the clinic, so I decided to convert it into a 2-minute video, as Ashok sir had once said that we can present it here on this platform.
Femtosecond laser assisted traumatic cataract surgery. There are no financial discussions. Lens on the loose. Lens on the loose. Femtosecond laser assisted traumatic cataract surgery. There are no financial disclosures. A 35-year-old male presented with trauma to the right eye with Rennes Paul around 6 weeks ago. He had shown elsewhere and was diagnosed with a traumatic cataract surgery with posterior capsular tear. On examination, his visual acuity in the right eye was counting fingers close to face with intraocular pressure of 60 mm mercury and a total white cataract. And ASOCT showed some capsular fibrosis with a dehiscence of the posterior capsule and the posterior pole. We explained to the patient that there was some risk of nucleus stroke owing to the thin capsule and vitreous loss as well. So he needed a 3-piece IOL, but our patient was adamant for a premium IOL as he did not want to wear glasses. We planned a femtosecond laser assisted cataract surgery for a better centration of the rhexis, and 2 IOLs were ordered. Femtosecond laser assisted capsular rhexis was performed. A gentle hydrodelineation was performed. Being a young patient, the cataract was relatively soft. We made sure that the nucleus was not rotated. And at removal of the posterior epinuclear plate, we were very careful, but we could see that there was presence of a large capsular tear. Interior vitrectomy was performed, and rest of the cortex was removed with the help of the vitrector. On tracing the capsular edges, we could see a lenticular shaped tear with fibrosis at the edges of the capsule. We placed a single piece EDOF IOL inside the bag because we hoped that the edges of the capsule that were fibrous would provide extra support to the capsule and also prevent it from running away. A single piece IOL was placed perpendicular to the site of the tear. On post-operative day 1, the uncorrected visual acuity was 6/6 with normal intraocular pressure. His fundus examination was within normal limits. The patient continues to have good vision for near as well as distance at 6 months follow-up without any aberrations. Thank you.
Thank you very much for showing us a new method of managing traumatic cataracts. Excellent video. We thank all the judges for judging this particular event, and we request you to please hand over your evaluation sheets to Dr. Rajan Sharma, and we will announce the results after the next felicitations for all the judges. Dr. Rajan Sharma will be doing the honors.
I request Dr. Sandeep Mahajan to please come to the dais and honor Dr. Rakesh Gupta. Now I request Dr. Dhami sir and Dr. R.S. Dhaliwal to please come to the dais and honor our speakers. चलो पहले स्पीकर हो गए फिर हो गए दिल बातें रोग डॉक्टर पवन पुनीत प्लीज
Dr. Pawan Prashar, Dr. Gaurav Sharma, Dr. Jitender Rudki. Dr. Nishad Bansal, sir. Dr. Nimrata Bajaj Dhami. Dr. Sonam.
May I request Dr. Basavaraj also to kindly accept our souvenir. Dr. Neeraj Sood also, please. Can you please come up? Professor Anil Verma, sir. Dr. Vikrant Sharma.
Dr. Gurmeet Mangat. Dr. Rajiv Tuli, sir. Dr. Amanpreet Kaur. Dr. Gursatinder, sir. Dr. Sahil, sir. Dr. Harpreet Kapoor.
Should I call the other chairpersons now? Thank you, everybody. We come to the last session, but not the least. And the chairpersons for this session will be Dr. Rajiv Gupta, Dr. Ashok Gupta ji.
Dr. Harpreet Kapoor, Dr. Faisal, Dr. Sonali, Dr. Amanpreet Kaur. I will request Dr. Basavaraj, Dr. Gurmeet Mangat, Dr. Dhami sir, Dr. Dhaliwal sir. Dr. Dhaliwal sir, please chair the session.
This is an assortment of cases. We have Dr. Nimrat Bajaj Dhami to speak on nano-emulsion based eye drop in management of evaporative dry eye. Will she be presenting this?
Yeah, I'm here.
Yeah, right.
Should I start, sir? Good afternoon. I'll be talking on nano-emulsion based eye drops and management of evaporative dry eye. So needless to go through the demographics, we all know that dry eye is hugely prevalent in our society, and whatever we are diagnosing is the tip of the iceberg. Whatever lies beneath is actually much more, and this disease has now causative. It has ocular elements and it has systemic elements, and now a vast majority comes from computer vision, because we are all, like it or not, addicted to our gadgets. So this classification of dry eye is, I think, outcome based, not causative based. Whatever is lost is how we are diagnosing the dry eye, but I think the classification should be cause based. And I'm going to be particularly focusing on computer vision syndrome, which we ourselves and see a lot in our clinic. So 4 out of 5 patients have, normally what we see commonly is evaporative dry eye. This is more commonly seen in our clinic. And what are the risk factors? Again, as we see, we have local factors like meibomian gland. There could be dysfunction in terms of there's a infection or a blepharitis or a blockade, or patients with acne also tend to have this lot, or ocular surface related, and very importantly, it could be systemic factors related. So these need to be particularly asked. And very important, nowadays we have blink related issue which has come from computer vision syndrome. Lid disorders, contact lens wearers per se are also very prone to have evaporative dry eye. What lies at the heart of evaporative dry eye and computer vision syndromes is the poor blink rate and incomplete blink. This is commonly seen if we ourselves do anything with a lot of intent. We're watching a screen or something, we forget to blink. And it does not, once we do not blink, it does not complete the whole cycle with which our eyes have to be lubricated, in which the mebum has to be secreted and spreads onto our eye surface, and the whole ocular surface homeostasis gets disturbed. There are a number of factors which we can see that they can affect the blink rate, going on from the age, gender, to various other local and systemic issues, and again environmental factors are also to play a huge role. Coming to digital eye screen and evaporative dry eye, again as I said, what lies at the heart is the decreased blink frequency or incomplete blinks which do not complete the cycle of secretion of mebum, causing hyperosmolarity, faster tear evaporation, hyperosmolarity, and cascading reaction leading to inflammation of the ocular surface and tear film instability, and finally ocular surface damage. So MJD is the most common cause of evaporative dry eye, the gland dropout or local inflammation infection. It can lead to more secretion of lipid degrading lipases, and then the whole viscosity and ocular surface homeostasis gets disturbed. Now, this is a very important way in which we treat evaporative dry eye. There is an outer circle in which we ask the patient for questionnaires or give them lubricating eye drops. This is where most of us keep treating. Then is the middle circle, and then is the inner gold ring, which is the complex treatment. Now, the outer circle is we need to first validate how much severe is the patient, what is the comfort time after blink test, and what is the blink rate and completeness. Again, so what lies important is that we need to assess and ask the patient, and the new modalities of diagnostic dry eye, they do work at assessing the blink rate, which needs to be carefully looked into. So we ask the patient to blink 3 times and then see after how many seconds does the patient start feeling uncomfortable. If it is less than 10 seconds, means it is significant of evaporative dry eye. And blink rate and completeness can be assessed with the machines that nowadays we have, or even with the infrared we can get a good idea if we do not have the proper dry eye modality with us. So the simple would be the questionnaires. Then we go on to the next part is doing the fluorescent breakup times. Then the lissamine conjunctival stainings can be seen. And what needs to be also corroborated is if there is some aqueous tear deficiency, because some of the dry eyes are mixed dry eyes. So what is the management? So the problem lies is that the corollary lies that most of the lubricants in the market, they actually supplement the aqueous layer. Nothing much is done to supplement the lipid layer. Although lipid layer deficiency in evaporative dry eye, as I said, is 4 out of 5 patients coming to our clinic. So lipid-based artificial tears, they are a step closer, and they actually work more where it is needed. And the traditional aqueous artificial tears, it is just a temporary outer supplementation. It does not have so much ocular retention time. So another lubricant I'm going to specify on is Sustain Complete. It has an added advantage of HP Goa. Now what it does is it forms a hydrophilic meshwork. It cross-links with the muco-aqueous layer, and it creates a plastic protective elastic matrix. Also, the size of the particles is so tiny that they can actually migrate the top lipid layer, which is tough to penetrate by most eye drops, and therefore they can repair the gap and cause damage repair. So if we see that it works on lipid, aqueous and mucous, all layers of tear film. Again, the mechanism of action is that there is a good spread. It is going to form a hydrophilic meshwork. It is going to entrate the lipid layer, and hence it's going to give us the much needed good ocular retention, viscosity, and prevention from the strain from digital strain. So it's working on all the layers, and the technology is such that the particles are very well titrated and does not cause much wastage. So the evidences from multicentric trial have suggested that patients are definitely benefiting for up to 8 hours. So as we can see, the fluorescent breakup time all get better. Coming back, I'm just going to come to an example of a case study. So, this is a 40-year-old male. He's come to us complaining of tiredness and dryness and irritation. What is important is that these patients also have a lot of neck, wrist issues. So, computer vision syndrome is not just for your vision. It's actually patients have a lot of migraines and neck aches and, tennis elbows, and all these things are there. So for these patients, it's very important when the knee butt and the Schirmer are normal, we start with something which is going to replace their lipid layer, and 3 to 4 times a day would be good, because the viscosity and ocular retention time of these drugs is very good, and they start the relief from day 1. So the conclusion is that it is evaporative dry eye needs to be properly diagnosed, looked into from the environment and ocular level both. And it is going to constitute majority of the dry eye that you see in our clinic. And lipid-based tears actually are much closer to the natural tears, and Sustain Complete justifies all the layers of tears. Thank you.
Thank you very much, madam, for that nice talk on dry eye. May I request Professor Anil Verma to kindly present his paper, his presentation on presumed ocular tuberculosis. Professor Anil Verma is a professor at Hamirpur. Thank you.
It's not coming.
Good afternoon, everybody. I shall be presenting presumed ocular tuberculosis. In 1882, Dr. Robert Koch has discovered Mycobacterium tuberculosis. And during those days, out of 1 person out of 7 used to die due to tuberculosis in USA and Europe. Mycobacterium, it has been prefixed by myco. Myco, it's a Greek word taken that means it's a fungus-like. So Mycobacterium tuberculosis is not a typical bacteria. It's basically a atypical bacteria, and its wall is made up of mycolic acid. And you can see this is a microscopic picture. Sometimes these bacilli are seen as branched. That is why the myco word has been added to this bacteria. And why it is atypical, again you can see it needs a multiple antibiotics to kill this. We need multiple antibiotics to kill this bacteria, and all these antibiotics, these act at different parts of the bacteria, like INH, it inhibits mycolic acid, rifampicin interferes with transcription, ethambutol hinders with galactic synthesis, pyrazinamide impedes coenzyme A synthesis. So tuberculosis has been declared as global emergency. 3 million people die every year, and 1/3 of the world population is infected with tuberculosis. And out of these, 90% have a latent tuberculosis and 10% have a active tuberculosis. And only 22 countries have 80% of the total burden of tuberculosis. And the situation has worsened due to coexistence with multi-drug tuberculosis and its coexistence with HIV. 80% of tuberculosis is due to pulmonary tuberculosis, and extrapulmonary tuberculosis accounts for 20% of the cases. And out of these 80% tuberculosis pulmonary tuberculosis cases, 1.4% have ocular morbidity along with the pulmonary tuberculosis. Main pathophysiology, primary active lesions, infections are seen in the lids, conjunctiva, sclera and cornea, and other parts of the eye, they have a hematogenous or immune mediated lesions. So diagnosis, it's very difficult to diagnose that it's definitely an ocular tuberculosis because physical findings are non-specific, biopsy is difficult, regions most plagued with tuberculosis are least equipped, newer advances like PCR, IGRA are costly, Montux is 49% specificity, it has 49% specificity, and again IGRA, it has a specificity of 96%, but it's also positive in the latent tuberculosis. So it's difficult to differentiate between an active lesion and a latent tuberculosis with IGRA or quantiferon gold test. So these are the signs and symptoms usually seen: blurred vision, or patient may be asymptomatic or may complain of headache, flashes of light, floaters, redness of eye. This picture shows few lesions which are caused by this tuberculosis, ocular tuberculosis, that is scleral, tubercular scleritis, and this is flectinular keratoconjunctivitis. This is a typical flectin. This is a lacrimal gland involved in the tuberculosis. This is conjunctival granuloma, orbital tuberculosis, and then a lupus vulgaris. And patient may present with anterior uveitis, posterior uveitis, choroidal tubercle or choroidal granuloma. So when the size of this tubercle is more, when the size is less than the size of the optic disc, we call it choroidal tubercle. When it's more than the size of optic disc, we call it choroidal granuloma. And you can see that typically if it's a small lesion and you want to differentiate between a cotton wool spot You can see the vessel crosses in front of the lesion. Then the patient may present with the vasculitis, a typical East disease, and which has been said to be caused due to tuberculosis. Then multiple granuloma with the retinal detachment, serpiginous choroiditis. You can see these are the peripheral active lesions. Then patient may present with optic neuritis or neuroretinitis. So I shall be presenting 17 cases of this ocular tuberculosis, basically a presumed ocular tuberculosis. Among these, two patients had fluctine and fluctular keratoconjunctivitis. 6 patients presented with anterior uveitis, 1 with intermediate uveitis, 4 with posterior uveitis, and 3 with panuveitis, and 1 with phthisis bulbi. So 13 years female presented with the fluctine in the near the limbus, and all these patients had a highly positive Montauk's test along with raised ESR. So these were our minimum clinical findings, which we took it as an tubercular ocular tuberculosis. Then case 2, this patient presented with the fluctinular keratoconjunctivitis, and in the other eye, 2 years earlier also he had a same lesion in the other eye. 6 cases of anterior uveitis. All these had a highly positive Montauk's test, and if you go through the newer regime of tuberculosis, that tuberculosis control program, now even the contacts with highly positive Montauk's are being treated with single drug regime for at least 3 months. 32 years female also presented with anterior uveitis with granulomatous uveitis with spillover vitritis. Then this is a 58 years male. He also presented with anterior uveitis. Then 52 years male. He also had anterior uveitis with a spillover vitritis. Then these 2 cases, 38 years female and a 58 years female and a 38-year male. These all presented with anterior uveitis. Then 1 case was with the intermediate uveitis. This patient also had a raised ESR and highly positive Montauk's test. And this young patient had a posterior uveitis along with multiple tubercular granulomas, along with there were tractional bands and retinal detachment. He was 28 years old.
Excuse me, sir, can you please wind up?
This is serpiginous choroiditis, and you can see after treatment with the antitubercular drugs. Then again, this is a B scan showing choroidal granuloma, serpiginous choroiditis, 3 cases of panuveitis. This child had in both eyes she had panuveitis, and she is the mother of the child. She was treated for pulmonary tuberculosis, and she had a phthisis bulbi in the left eye. This is an antitubercular treatment which is usually given with the multi-drug treatment. Then take-home message is all tubercular patients should be evaluated for ocular morbidity, and in a newer regime, they have increased the period of treatment with the ethambutol, that is, it's given in the both phases. So we have to be very particular about the retrobulbar uveitis also. Patient should be instructed if he or she has a vision defect, he should immediately report to a physician or an ophthalmologist. Thank you.
Thank you very much, sir, for drawing our attention to the common problem in our situation. It's Dr. Sonam Yangsis again, who will be presenting a fibrin glue rescue for large iris cyst in an infant. Dr. Sonam Yangsis is Associate Professor at PGI.
Assistant Professor. So, hello again. So, being a film festival here, so I have a video instead of a talk, just a short one.
IOCT guided management of a large iris cyst in an infant. There are no financial disclosures. A 6-month-old infant was brought by her parents with complaints of inability to open the right eye since birth. Her antenatal history was unremarkable. On examination, her intraocular pressure was 10 mm mercury with presence of a large iris cyst obscuring the visual axis. Her left eye was within normal limits. ASOC to the right eye shows a large iris cyst filling the anterior chamber, measuring up to 2.8 into 6.7 mm. UBM also shows similar findings. Management options in primary iris cysts include cyst aspiration alone, but this is not routinely practiced as this is associated with higher risk of recurrences. Other options include injection of sclerosing agent, which has lesser risk of recurrence. But sclerosing agents are quite toxic and caution has to be practiced as it can lead to local toxicity. Other methods like en-bloc excision is associated with greater risk of collateral damage to the surrounding tissues along with intraocular pressure elevation, inflammation and corneal decompensation. We did a literature search to look for a non-toxic alternative. We came across this paper which shows use of fibrin glue for a large iris cyst with good results. I wanted to go ahead with this technique because fibrin glue is biocompatible and its efficacy has been proven for intraocular use as well. In our case, we believe the fibrin glue would facilitate adhesions between the cyst wall, thereby enabling complete resection without any collateral damage. We went ahead with a stepwise approach, first step being aspiration of the cyst contents, followed by injection of the biologic fibrin glue inside the cyst cavity, then resection of the walls at the later setting. IOCT guided iris cyst aspiration with fibrin glue. Use of IOCT helped us in visualizing the cyst in real time. We could localize the position of the needle inside the cyst cavity that helped us in preventing any collateral damage. First step was aspiration of the cyst contents. We can see the cyst wall collapsing. This was followed by injection of the first component fibrinogen inside the cyst cavity, followed by second component. The case was then closed. Cytology revealed absence of malignancy. At 6 weeks follow-up, her intraocular pressure was 10 mm mercury with collapsed cyst walls. We followed this case with third step, that is cyst wall excision after injecting viscoelastic under the endothelium. Iris spatula was used to separate the cyst wall from the endothelium and the angle. This was followed by excision of the cyst, which was sent for histopathological examination. Remnant of the cyst was then removed with the help of cutter. Peripheral iridectomy was performed and the ports were sutured. Histopathology showed benign pigment epithelial cells lined by non-keratinized stratovascular epithelium. At 4 weeks, we can see there's absence of any recurrence. At 1 year follow-up, the cornea has cleared out with absence of any recurrence. The visual axis was parallel. Patching therapy was continued. So to conclude, biologic fibrin glue can be considered as an alternative to toxic sclerosing agents. Stepwise approach ensures minimal damage to the surrounding structures. More studies are needed to prove the efficacy and safety of fibrin glue in large iris cysts. Thank you.
Thank you very much.
Thank you very much, Dr. Sonam Youngsis. Do you think that if you don't have access to an IOCT, do you think that the whole thing gets a little harder?
So we can just follow a few steps in that situation, because here we could visualize the cyst wall and the cavity in real time. If we don't have the access to IOCT, one can make sure that one can leave air bubble inside the cavity so that we can visualize it through the microscope better, or maybe leave some residual cysts before injecting thrombin and fibrinogen. That way the cyst wall will not collapse completely, thereby it will help us in visualizing also the cyst.
Thank you. Thank you
sir.
very much. May I request Dr. Aid Al-Assa, who has come from Himachal. He is a third-year resident in Solan, but originally from Australia, I was told.
Originally from Iraq. I live in Australia. Thank you all. So I would like to present a case that caught my attention back in 2019 when I first joined MMU. Acquired total anterior staphyloma in a middle-aged man. So the gentleman is a 44-year-old gentleman, originally from Nepal. He gave a history of vague history of corneal injury at a young age. Subsequently, he said he got infected, been to many health professionals for treatment. He also gave a history of gradual, painless diminution of vision. And eventually, as a teenager, he lost his vision. He has noticed that his cornea is bulging or protruding and changing color. On and off, throughout his history, he was having multiple infections and conjunctival redness, watering. During his presentation, he didn't have any discharge. He's generally a healthy individual with no systemic or noticed systemic disease, such as diabetes and hypertension, and no history to suggest or drug use to suggest immunocompromising. He has no history of ocular diseases in the other eye. A single gentleman, he's live on his own, non-smoker, non-drinker, a short spell with illicit drugs as a teenager, but not after that. His examination was unremarkable in the right eye, however, in the left, we can tell from the subsequent pictures that he has no vision in the left eye. His blood pressure was maintained both eyes, however, he was on IOP, so I'm not sure if that's related to that. Obvious corneal protrusion, grayish black in color with surrounding conjunctival redness. The cornea was irregular, doesn't have any shine to it. Colors was between gray to black and some purple area as well. Serum test was positive and he has no sensation in his cornea. So we were arguing whether this is a case of staphyloma or something else, but it's clearly from the pictures and examination it was a case of staphyloma rather than a differential. As B scan showed no vitreous haze and retina was on. Slit lamp examination revealed that smooth surface with some vascularization at 11 at 1 p.m. So we come to the diagnosis of left eye anterior staphyloma. We offered him some temporary measures such as artificial tear because he didn't have any sensation, some IOP lowering medications, antibiotics drops due to the conjunctival redness. I advised him to have some protective sunglasses and we asked him for follow-up. That was in 2019. He doesn't come often for follow-up. But I have suggested to my seniors that this gentleman should have definitive treatment, and they were thinking about that before I asked them. So he was sent for oculoplastic opinion. Discussion I would like to have about this case, what options we can give him as a treatment, as a definitive treatment. Literatures are divided about what's the best action to take. Some people suggested evisceration and others some less intrusive procedures. Such as sclerokeratoplasty. So what is staphyloma in this case? It's localized thinning and bulging of the outer layers of the eye ball caused by thinning and protrusion of the cornea and the surrounding sclera. Colors ranges from bluish to black to purple due to the visible underlying pigmented layer. As you can tell, in this image, it could be anterior staphyloma, posterior, equatorial, intercalary, and ciliary. That's some of the images which I copied from others, depicting different types of staphyloma. It is not a true cornea, it's a pseudocornea. It's formed with fibrin and exudate, and covered by conjunctival cells. So what are the treatment options? Again, the literature are divided. Some people say given a lubricant, IOP control, contact lenses, protective glasses, and you can offer him sclerokeratoplasty in single or two-stage. Some names mentioned, but I'm not sure about these. Dual graft, mushroom, tibial graft, evisceration with cosmetic implant. That was suggested to him by our department. And thank you.
Thank you very much, Dr. Essa. May I request Dr. Harpreet Kapoor to please felicitate Dr. Essa, please.
No?
No, your mission is accomplished in the morning. May I request Dr. Basuraj Tigari, who is from my state, he is associate professor in PGI. There are only two sets of patients who don't, two sets of doctors who have no complications. They say one who doesn't operate enough numbers and the other one who is being economical with the truth. So Dr. Basuraj will be telling us about one such.
Thank you, sir. Thank you for
Not
the
always
wonderful
a smooth
introduction.
sailing. Challenges and complications are awarded to those who tread a difficult
discussion here. So in this video presentation, I'll be showing a few commonly encountered intraoperative retinal surgery complications and their management. So let's see.
Smooth sailing. Challenges and complications are awarded to those who tread a difficult path, but one who finds a way to navigate through them will achieve surgical success. In this video, I shall describe various intraop surgical challenges and surprises faced. Case 1. Scleral buckle and belt loops are a major part of ER surgery. With them come a major share of complications and challenges. In this case of a myopic pseudophakic rhegmatogenous retinal detachment, while securing a belt loop with a Dacron suture, there was an unintentional scleral perforation which can be noticed by a sudden giveaway feeling. This complication can be avoided by avoiding the areas of scleral thinning and following the Jenkins rule of visualizing the needle throughout its course. Intraocular visualization of breaks and its treatment is vital. Anterior PVR is always a difficult task to conquer. Taut anterior retina poses many surgical challenges. In this case of an old rhegmatogenous retinal detachment with significant anterior PVR, PFO acts as a third hand. But in presence of such a large break, there is always chance of subretinal migration of PFO. Adequate release of anterior traction aids in avoiding and managing such complication efficiently. With the advent of MIVS, tackling of PVR and complicated retinal detachments has become relatively easier. Sometimes these star folds have a tendency of a strong underlying adhesion. In such cases, there are high tendencies of creating iatrogenic retinal breaks. Utilization of bimanual techniques may be of great help in such scenarios to avoid iatrogenic complications. Pediatric retinal detachments are always a hard nut to crack. Managing them needs diligence and patience. The following is a case of ophthalmos with rhegmatogenous retinal detachment. After the completion of pars plana lensectomy, PVD was induced and vitrectomy was completed. In such cases, the anterior lens capsule is removed to avoid fibrosis and contraction of the lens capsules. Forceps is one of the commonest instruments used to remove the remnant capsule. But the zonular attachment in these eyes is significantly stronger. In such cases, there may be a development of iatrogenic giant retinal tear. Therefore, in such eyes, careful removal of the capsule is vital key. Being a surgeon, one should always have an instinct to think outside the box in tricky situations. In this case of a redetachment under silicone oil, after the removal of silicone oil, triamcinolone was used to stain the remnant hyaloid. The remnant hyaloid was removed with the help of intraocular forceps, following which the vitrectomy was completed. But we noticed a sudden large bullous retinal detachment localized to inferotemporal quadrant. The first instinct would be to check subretinal migration of infusion cannula, which was not the case. So PFO was injected at the posterior pole with the hope of visualizing it, which also went in vain. At this moment, the surgeon decided to drain the subretinal fluid externally. A 25 gauge valveless cannula was used to drain the subretinal fluid externally at the highest point, following which a small horseshoe tear was noticed in the superotemporal quadrant, which acted like a trap door, causing the fluid misdirection into the subretinal space. In this case, the surgeon's diligence and outside the box thinking saved the day. In a limited resource setting, reusable consumables are popular. Although these are efficient, with the repeated use, they carry their fair share of concerns. In this case of an epiretinal membrane peeling, a silicone tip was used to inject the dye to stain the eye limb, during which the intraluminal part of the silicone tip extruded from shaft onto the retinal surface. Although this is clinically inert, such a large silicone material has to be removed to avoid the occurrence of floaters to the patient. An intraocular forceps was used to bring the silicone tip anteriorly and under visualization from the other port with the handshake technique. The silicone tip was exteriorized through the port site. So, what did we learn? Challenges and complications are an essential part of VR surgery.
What did we learn? The challenges and the complications are essential part of VR surgery, which help us to learn better. Every surgeon must be watchful at every step and anticipate these challenges. Sometimes unusual problems need unconventional solutions. So never shy away from taking risks. Be gift and hands to those needy eyes. Thank you.
Thank you very much, Dr. Basuraj. That was an excellent presentation. We have Dr. Pavan Puneet to present his next video. We have seen many of his breathtaking videos in our alumni groups. So he will be presenting one such. It's about the approach and surgical management of subretinal bleed in various ocular pathologies. The results of the previous session on 2 minutes to win will shortly be announced. It's getting ready. So I request you all to kindly await the results. Meanwhile, I request Dr. Sahil Jain to be ready with his next presentation. And the last presentation of the evening will be by Dr. Ashok Sharma, who will be talking on perioperative dry eye management in cataract surgery. अभी सिर्फ इस
Very good afternoon to all of you. First of all, thanks to Dr. Ashok sir for the invite to the talk. Retinal bleeds, as all of us know, that it can present from vitreous segment to the sub-ILM to the subhyaloid or the intraretinal or the subretinal as caught in a single frame in one of my patients. And today we'll be talking about the subretinal bleeds. They can present from minimal bleed to a massive bleed at time like this. And but what's the need of removal of this bleed? First of all, the iron is toxic to the photoreceptor. Fibrin has a shearing stress on the photoreceptors, and the clots at times can get fibrovascularized. The causes all we know that most commonly being the AMD, RAM, and the trauma. And prognostic-wise, if the size is less than 4 disc diopters, duration less than 2 weeks, thickness up to 300 microns, and the etiology, if the obviously choroid not involved, we're going to get a good prognosis in these cases. Like this case of trauma, we can see that just with the help of a pneumatic displacement, we could get the vision of 6/9 over 4 to 6 weeks. And you can see this nice choroidal rupture abutting just a foveal region, so not involving the fovea. One-eyed patient present to us with a scar in the other eye and the CNVM complex with a bleed. So we opted for the pneumatic displacement along with the anti-VEGF, and patient improved to 6/12 in 4 weeks. Advised 3 anti-VEGF injections, but as usual lost to follow-up. Presented again after 3 months with a bleed. One-eyed patient, again opted for the same pneumatic displacement along with the anti-VEGF, and then thereafter multiple anti-VEGF injection, and the vision we could gain up to 6/36. Patient with a large bleed, but the other eye was good, so we opted for the approach of using the subretinal BSS or TPA along the ear. So what we do the vitrectomy, do the base dissection, we assess the size of the bleed. Thereafter, we use a vent so that when we increase the pressure inside, there is no increase of intraocular pressure. Then the cocktail of either BSS air or TPA air is injected. You can see the BSS came, then the air came. This is followed by the partial fluid air exchange, and the patient is kept upright for the 5 days to gain good vision, and the blood gets displaced inferiorly. You can see that air bubble lying there. And at times, sometimes the subretinal air and the gas can be caught in a single frame, like in this case. And the large bleed from the fovea was displaced. Very, very rarely when it presents with such large massive bleeds and the patient is not having a contraindications for the anti-VEGF, have a financial issues also, like the lady, this was a case of a lady of 88 years female from a hilly area. So what we opted for, doing a RP choroid graft, in which you do the vitrectomy, do the base dissection. Thereafter, you do induce a localized detachments in the area of the abnormal pathology as well as in the area of the normal RP choroid. Then you use the fax to push the fluid behind. RR for more than 180 degrees done. The retina is everted, and thereafter I tried it with the help of soft extrusion cannula with the active phase on. Thereafter, all the complexes of CNVM, all the bleeds, all the scars removed. Then the feeder vessels were cauterized, and the anterior attachment to the retina was too separated in this case. Thereafter, under the PFCL, you see from the area of a normal graft with RP choroid, first mark it, it should be around the size of 4 disc diopter. You mark it with the help of a cautery, then with the help of a curved scissor, you can see the underneath sclera now white shining underneath. It is transferred to the center of the retina, taking care not to touch in the center. From then, the PFCL is taken from behind and put on the retina. This is followed by the laser and the PFCL oil direct exchange. You can see that this was a post-op outcome in this case. The graft being nicely placed. Thankfully, the lady who was advised at least 18 injections did not require any injection thereafter. And thanks to God, she could gain some vision of half meter too. Post-block perforation, high myope, the lady present with multiple perforation. I could not see anything until I cleared up some of the blood. There I could make out these 5 perforation on the posterior pole. So what we did, you can see the subretinal bleed along with the sclera shining there. So ILM flaps were plugged in there. Along with the big ILM flap was used as a scaffold to cover the big large, this crescent-like tear there. And the lasers were applied to the peripheral breaks and the peripheral vitreous was cleared. And the good outcome was at the site of break as well as the site of the subretinal bleed, it resolves over time. So this is a very, I would say, emotional case for me because the patient was totally blind. Young patient presented to us with one eye being other eye had the trauma in the childhood, and so detachment along with the bleed. So it was difficult to induce the PVD even. So we induced the PVD in an area and tried to use the PFCL to push the retina behind. Then we tried to take this large sheet of subretinal blood with the help of extrusion, but it was not coming. I used the left hand to give it a counter traction with the help of my endolite, but it was again not coming. Then I thought to make a spaghetti like use of the cutter to hold that and it roll it over it and take it with that. The rest of the blood was taken, and I was lucky enough to see the patient walking to my clinic at 2 months in this case. Diabetic with subretinal bleed, this is a lady from Delhi who came, young lady, 45 years age, lost one eye to NVG, other eye, the state is in front of you. So the vitrectomy was done. Thereafter, after clearing the whole of the vitrectomy, we could see still the tabletop detachment behind. So thereafter, after removal of all these traction, and they put the PFCL to save this subretinal blood to get migrate to the fovea, and all these clots were removed from the periphery, with peripheral break followed by the laser, and this patient gained a vision of 6/24. At times, in one-eyed patients, blind patients, you have to remove this clotted blood also from a retinotomy, and you can gain a vision of 1 meter, which is enough for a blind patient at times. The retina, you can see, it got attached in a video you can see there. Very rarely.
Dr. Pawan, I think we will have to wind up because we have to vacate the hall by 4:30.
External drainage, you can try in these cases where whole of the blood along with the serosanguinous comes. So to conclude, I would like to say, in small bleeds, you can observe bit large pneumatic displacement. Surgical approach should be sought in the cases where the bleed is slightly larger, and very rarely you should opt for these RP choroid grafts. Thank you so much for your patient hearing.
Thank you very much for the wide array of cases, excellent surgeries. May I request Dr. Gaurav Sanghi to please present his video on management of complex retinal detachments. I request all of you to please stick to time because the hall has to be vacated by 4:30.
I would like to thank Dr. Ashok Sharma for giving me the opportunity to present my work. So I will just quickly discuss some of the cases. These are just videos. So this first case is a retinal detachment with a giant retinal tear. So in a case with giant retinal tear, what is important is that we have to cut all the vitreous. Especially we have to take care of the flap of the giant retinal tear. PFCL bubble comes out. So the case 2 is a retinal detachment with subretinal PVR. So this was a one-eyed gentleman who had a previous surgery for detachment with silicone oil. Silicone oil was removed, and he made a retinotomy over the subretinal band. The band was clasped conjugation and gripping forceps, and the bands were dissected out through this retinotomy. The fraction of them was adjusted according to the orientation of the bands. Sorry. So this is another case. So this is a case of a young chap, 32-year-old, who had extensive retinal detachment, and after the first PPP surgery, the retina was partially attached. So here we're putting the scheduled light. We remove the silicone oil first, and do an extensive pre-retinal as well as subretinal PVR. So here we are removing the PVR, which is pre-retinal. Subretinal silicone oil was removed with active suction, and so now the retinectomy flaps are kind of folded up. They were reverted by PFCL, and some amount of retinectomy was completed. We completed the retinectomy, and now we are doing a fluid air exchange, and we dried up the margins of the retinectomy. This eye gained up to 660 vision at 3 weeks, and the retina was on. So here is another case. In extensive myopic eyes, we should note that in myopic eyes, even other than the macular hole, small posterior pole breaks can also lead to such extensive kind of retinal detachment. So just showing a video clip from the surgery, so we could find out the very small posterior pole break. So it's very tiny growth. We cauterize that, and we could drain out the subretinal fluid from the break as well as the peripheral break. So, and the patient, gained a 360 vision. Another case which is challenging is a myopic macular hole with RD because of the long eye and the instrumentation required for it. So in these eyes, it is very important that there is a bridging membrane on the surface of retina. So here we have stained this bridging membrane with Canacot. We are removing the bridging membrane. And this was a case of deep attachment. We put in this is the last. So this, the vision, this case finally improved to 618 with full closure of the macular hole. Thank you.
Thank you very much for showing us different varieties of complex detachments. Dr. Sahil Jain, please, for his presentation on vitrectomy in post-PK trauma eyes. Dr. Sahil Jain is vitreoretinal surgeon who has done his junior and senior residency from PGI and currently is in private practice.
Very good evening to everybody, and I thank Dr. Ashok Sharma for the opportunity. So I will be presenting some data on vitrectomy in eyes with post-PK trauma. So the main indications for such vitrectomy in these patients are retinal detachment, vitreous hemorrhage, endophthalmitis, and dislocated nucleus. This is a paper in Eye which shows that the traumatic wound dehiscence after PK is a real cause of concern, especially with the posterior segment complications with vitreous loss in 74% and vitreous hemorrhage in 32% and retinal detachment in 21% of the eyes. So the problems with VR surgery in these eyes is first is the grave concern of graft failure and graft rejection, and then the poor post-operative results, with most being the late presentation and severe PVR in such eyes, and the risk of redetachment, hypotony, and choroidal effusion, and the need of multiple surgeries in such kind of patients. So in this study, we included the eyes with PKP and posterior segment complications, followed trauma, and the minimum follow-up of 6 months was included. Pre-operative data like best corrected vision, intraocular pressure, slit lamp exam, indirect ophthalmoscopy, and OCT and B-scan wherever required and possible were done. So coming to the surgical approach in these kind of patients, counseling is very important, as these patients need to know the risk of the surgery and the results of the surgery. In these kind of surgeries, the corneas are clear to begin with, but graft becomes hazy as the surgery progresses, and we can debride the epithelium to have a clear view. In cases of detachment, there needs to be an encirclage like scleral band, and we can coat the endothelium in such eyes and viscoelastic in aphakic eyes so as to present a clear view, and minimum manipulation in the anterior chamber so as to preserve the endothelium. Posterior vitreous detachment should always be done, and the close shaving of vitreous base is necessary, and the port should always be closed because these eyes are great risk of hypotony. So the port should always be closed in such kind of eyes. So coming to a representative video. So after doing the core vitrectomy, the PVD is reduced with staining with triamcinolone, and the rest of the vitreous is cut. The PVR changes are dissected segmentally, and the vitreous base is shaved with the help of depression. All the breaks are cauterized. Also, one can do ILM peeling if he finds that there is a contraction of the posterior pole, like in such cases. A retinotomy is made, fluid air exchange is done, and the laser is done to all the breaks, followed by laser to all the breaks and injection of the oil. So coming to the first case, this was a 41-year-old male. He had a PK done in 1998. Graft was fairly clear till June 22. But after that, a trauma happened, and it resulted in the expulsion of crystalline lens, and graft was dehiscence. Graft was resutured. He had retinal detachment 4 days later. Scleral band with PPV with laser and oil was done in July 2022. This is the B scan of the patient showing a retinal detachment. These are the post-operative day 1 month photographs. These are taken on the slit lamp, so they are inverted view showing the retina is on. This is 6 months post PPV showing that the graft is fairly clear, and it showed a deficit of 960 cells per mm square from the pre-operative cornea. This is at 6 months, the eye is on, and now we have a follow-up for this patient for 2 years. The retina is still on, and he is enjoying a vision of 6/60. Coming to the case number 2, this was a patient who had a PK done, but he was a farmer and had a trauma. The graft melted. Therapeutic penetrating keratoplasty was done. He developed endophthalmitis over the next 2 days, and we did a core vitrectomy with a vitreous tab and intravitreal antibiotics. This is the second day post PPV. The graft is fairly clear, and we can see that the retina is on. This is 1 month post PPV showing retina to be on, though there is almost total cupping of the disc here. And it shows up ERM at the posterior pole, but the retina is on. So coming to the results, we had almost 24 eyes with post-PK trauma, but out of them, 12 had a post-PK posterior segment complications. 7 had retinal detachment, 1 had a retinal detachment with serous choroidals, 3 had vitreous hemorrhage, 1 had a vitreous hemorrhage with a hemorrhagic choroidal detachment, and 1 had an endophthalmitis. 1 patient of them had a retinal had a redetachment, and we had a follow-up of from 12 months to 42 months. All patients at presentation had visual acuity of hand movement or below, while the mean logMAR visual acuity improved from 2.3 to 0.825 logMAR, and almost more than 50% of the patient enjoyed a vision of more than 6/60. All the patients had the retina attached at the last follow-up, and 7 patients had the post of silicone oil and encerclage 240 band. In these kind of patients, sometimes you have to keep silicone oil for a long duration because they might have a hypotony as the oil is removed, because ciliary body shutdown may be there. And the graft was clear in 11 patients. 1 had a regrafting done. The average endothelial cell loss for these eyes was 884 cells per mm square at 6 months, more so in aphakics. So to conclude, PPV in eyes with PKP can provide a good anatomical and functional outcome. These eyes are at high risk of graft opacification, dehiscence, retinal redetachment, phthisis, and atrophic bulbi. There could be need of multiple surgeries which need to be explained to the patient, but the vision can improve significantly and the patients can enjoy a great lifestyle after PPV in such scenarios. Thank you.
Thank you very much, Dr. Sahil Jain. Nice videos in tough situations. Nice synergy between Ashok Sharma and Sahil Jain, I should say. May I request Dr. Ashok Sharma to please present his talk on perioperative dry eye management in cataract surgery.
Good evening. Dry eye, as we know, is a very common problem and it's difficult to manage. But if it comes to the cataract surgery in dry eye, it becomes all the more difficult and challenging. Dry eye, it increases cataract surgery increases the dryness of severity of the dryness, and those patients who are not symptomatic, they become symptomatic after the cataract surgery. Dry eye influencing several situations in our cataract surgery. The intraocular lens power calculation, toric axis and magnitude estimation, keratometry measurements, topographic measurements, all these are affected when we are performing cataract surgery in a dry eye patient. So to manage the dry eye, we need to treat dry eye before doing the cataract surgery, and we avoid multifocal IOLs in moderate to severe dry eye patients, because these patients may not be very happy after cataract surgery, premium IOLs, and selection of the wrong IOL or wrong power again is a problem. So we treat dry eye, and once the dry eye is stable and you get stable readings, then only we perform the treatment. Regarding the treatment part, we have several options. But recently we have a combination of sodium hyaluronate and HP guar polymers and in a single artificial tear. And this synergies the properties of the separate polymers and improves the ocular bioavailability of the active ingredients, which may result in enhanced ocular surface benefit to the patients with dry eye.
Sustained hydration.
I will just show this video to highlight the action of combined sodium hyaluronate and HP guar.
For dry eye patients with a compromised tear film, this formula contains both hyaluronic acid and HP guar, a unique combination proven to deliver 2 times greater moisture retention compared to hyaluronic acid alone. On the eye, the solution becomes elastic and spreads over the surface of the cornea. Together, HA and HP guar adhere to the muco-aqueous layer of the tear film, as well as the cells in the epithelium. This unique chemistry acts as a bandage, creating a moisture layer that provides increased hydration, with 2 times better protection against dryness versus HA alone, with 2 times the lubricity. This allows for improved corneal healing and symptom relief for patients with dry eye. Help your patients feel unstoppable with the long-lasting relief of Cystane Hydration Lubricant Eye Drops.
So combination is much better compared to the separate drops, and this is a preservative-free combination, and cataract surgery can both induce dry eye and exacerbate the pre-existing dry eye. Dry eye disease can impact the pre-operative planning, IOL selection, impair the healing and visual recovery. Dry eye can substantially affect patients' perception of their surgery and their level of satisfaction. Artificial tears are the mainstay of the treatment for better outcomes. And in the end, I would like to emphasize that combination of sodium hyaluronate and HP guar based artificial tears are helpful in optimizing the ocular surface, provides moisture retention, reepithelialization and symptom relief, and is beneficial before doing the cataract surgery and also after cataract surgery. Thank you so much for patience.
Thank you very much, Dr. Ashok Sharma. May I now request Dr. Mangat to please felicitate Dr. Ravi Nab and Dr. Gaurav Sangi. Post the felicitations will be the all-important results of the 2 minutes to win. Dr. Gaurav Sangi, please come up to receive our souvenir. So here are the much awaited results of the 2 minutes to win. The third place goes to Dr. Sonam Yangses for her paper on femto-assisted traumatic cataract surgery. Dr. Dami sir, again, please do the honors. I request Dr. Dami to please stay on, to please give the awards to the other two. The second place goes to Dr. Rajan Sharma for his paper on Taylor Bird suturing technique in eyes with positive pressure during penetrating keratoplasty. The father-son duo deserve the prize. Like father, like son. And who do you think is the first place winner? Dr. Nishad Bansal for his case on notorious case of optic disc maculopathy. Congratulations to all the winners once again. Thanks, sir, for doing the honors. And we come to the last part, which is vote of thanks. Dr. Rajan Sharma, who has so far remained backstage, will now be coming to the fore.
Thank you everyone for your sparing your valuable time and attending this conference. Without your support, this conference would not have been possible. I thank all chairpersons, judges, all our senior ophthalmologists and our colleagues, and also all the companies who helped us and motivated us to conduct the CME. I invite Dr. Kumar for last couple of lines of this conference, please.
I must say that this has been a wonderful experience, and I must really congratulate Dr. Ashok Sharma and Dr. Rajan Sharma for this wonderful event. As I alluded to this in the beginning itself, both of you are in private practice, and being in solo practice, I know that there are so many challenges, that you are already working neck deep in your own problems, and to have a conference and to invite people and to disseminate knowledge is really a wonderful thing for both of you. On behalf of all the participants, I heartily congratulate you and wish that you keep up the good work. I think they deserve a rich round of applause, both of them. And
I thank Dr. Kumar first because he came all the way from Bangalore, and we had full confidence in him because of being our star anchor.
The fact is, I invited myself because I kept on asking him, "Aapka pehle kaisa hua, dusra kaisa hua?" So he got the hint, and teesre mein aap aa jao. So I request all of you to please come on to the dais for a photograph, and after that we part till we meet again.
Cheers to Dr. Ashok Sharma.
Sir.
Okay, doctor. Okay, ji.